Breast Cancer Awareness virtual seminar focusing on prevention and treatment. We are in for a very insightful session. I'll leave it to the experts to educate us. Without further ado, as always, let's start this session with a prayer. Can we all bow our heads? In the name of the Father, Son, and Holy Spirit. Dear Lord, thank you for the goodness and mercy that we receive every day. We thank you for blessing us with another day and for bringing us together. We've met to discuss the prevention and treatment of breast cancer, an ailment that has touched many in different ways, directly and indirectly. We implore you to heal all sufferers, protect all survivors, comfort all who have lost loved ones, and keep breast cancer and all other diseases at bay from us all. Please come and take center stage in this meeting. Guide the moderator, the keynote speaker, the panelists, and open the ears of all the listeners. Grant us the wisdom to make this meeting a productive one, that the knowledge imparted by the experts is all taken in by all present. And at the end of this session, we all depart equipped with a better understanding and the ability to inform others. This we ask through Jesus Christ, your Son. Amen. As promised, I did say it was my voice that you were going to hear for the next few minutes, so the next session now. It is an honor and my pleasure to introduce the moderator for this event. She is a board-certified general pediatrician and pediatric hospitalist at the Children's Hospital of Philadelphia, and a clinical associate professor of pediatrics at the Perelman School of Medicine, University of Pennsylvania. She provides care to hospitalized infants, children, and adolescents, as well as primary care for newborns to minors. Her area of expertise is in the management of children with chronic problems, with a focus on sickle cell disease. She has collaborated internationally with researchers and healthcare workers in sub-Saharan Africa. At the Children's Hospital of Philadelphia, she has worked as an attending physician in the Special Immunology Clinic, providing care to HIV/AIDS affected and infected children, and served as the Associate Medical Director for the Rehabilitation Hospitalist team in a highly collaborative management program with rehabilitation physicians, nurse practitioners, and therapists. She graduated from Harvard Medical School and completed her residency at Boston Children's Hospital and Boston Medical Center, followed by an academic general pediatrics fellowship at the Children's Hospital of Philadelphia, where she completed 3 years of training in sickle cell disease in the Division of Hematology. She has a clinical research certificate for the Center of Clinical Epidemiology and Biostatistics, Perelman School of Medicine, University of Pennsylvania. Ladies, and I don't know if there are any gentlemen here, it is with immense pride that I introduce to you our moderator for this session, a member of the faculty in the Global Health Program at the Children's Hospital of Philadelphia, a fellow HOPSAW from the Holy Child School Cape Coast 1986 year group. She is no other than Dr. Jacqueline Owusu-Mackenzie. Over to you, Jackie.
Oh my goodness, thank you so much, Mr. AC. It's always embarrassing when the moderator, who's really not part of this, is given such a large and long introduction. So I apologize. Thank you for that really generous introduction. I am just thrilled to be here, and thank you for inviting me to moderate this a very, very important topic that affects all of us. All of us, we're all women, we have mothers, we have sisters, and and this is something that's so dear to our hearts. And I actually want to dedicate this talk to our sister who passed away recently, who is a member of the class of '85. So I'm just going to pause for just a few seconds for us just to say a prayer for her. Thank you very much, and may her soul rest in peace, and we miss her very much, and we will pray for her and for her family. So this is a very exciting October day. We picked a really good day to have this session, so I hope everybody everywhere is having a wonderful Sunday. As we are holy children, we're not surprised that we are having this event on a special Sunday. And so we really want to thank everybody for joining us, because we know that you could be doing other things, but we also know that this is so important, and we all want to make sure that we leave here knowing how we can make sure that our kids are well cared for, our parents are well cared for, and that we take care of ourselves. So I am so pleased to start this day with to introduce our very first speaker, who is a close friend of mine. I'm going to full disclosure. She is, we went to medical school together, and she is my very, very best friend, and we lived together. So I know her really, really well. And she is no other than Dr. Kemi Babagbemi, who is going to be giving us our first panelist talk. Kemi is a native of Lagos, Nigeria, though she likes to pretend that she's from Ghana. She is Associate Professor of Clinical Radiology and Vice Chair for Diversity, Equity, and Inclusion in the Department of Radiology at the Weill Cornell Medical College, Cornell University. She received her medical training and residency at Harvard Medical School. She is class of '98. During her time at Weill Medicine Radiology, she served as faculty scholar in health equity for the Diversity Center for Excellence from 2019 to 2020. She was also chief resident at the Brigham and Women's Hospital when she was a resident in Boston, which is Harvard Medical School. She's also an assistant program director of the radiology residency program, or she was from 2006 to 2014, and she's now moved to bigger and better things. She's an expert in women's imaging, specializing in breast imaging and pelvic ultrasound. Lately, Kemi's work has focused on improving diversity and inclusion in healthcare settings, and in understanding and addressing health disparities as it relates to the access to diagnosis and treatment of disease. Kemi is a very busybody, and you'll get to know her really well, but she just recently also got an award for helping the students, the medical students in Ukraine, find other medical positions, medical schools in Europe. She did this single-handedly. She got some friends and she fundraised for them, and recently was recognized for making sure that several African students were able to continue their medical school after they were displaced from Ukraine. By promoting systemic changes and identifying educational models that are culturally responsive, her work and her research promotes diversity in healthcare professions, as well as culturally competent and patient-centered care. For her efforts, she was recently granted another award, the Jean and Herbert Siegel Award for Excellence in Medical Education at Cornell Medical College. And I'm very pleased to say that this was the first radiologist in the history of the medical school to receive this highest honor. And she's also recognized as a fellow of the American College of Radiology, which is bestowed on the top 15% in the field. So those are the things that we call the words, but I'm here to tell you that she's truly an amazing, warm, and special friend. And I'm so honored to be the one to introduce, and that she's the first speaker for this session. Without much ado, let's welcome our sister, Dr. Kemi Babagbemi.
Thank you so much, Jackie. I hope everybody can hear me. I think I feel very honored to be part of this group. And I'm just going to assume I'm a member of your Old Girls Association, just as I'm probably an old girl from Queen's College, Yaba, Lagos. And hopefully there are a few of my classmates who are here with me today. So my job today is to basically tell you about something that's near and dearest to my heart, which is the issue of screening and diagnosis of breast cancer. As a radiologist, this is part of a lot of what I do every day, and it is very important and near and dear to my heart. So first, let me start by just helping everybody understand what breast cancer is. We hear about it a lot, and it sounds very scary, but cancer basically is the disease where the cells in your body basically start to grow out of control. When we talk about breast cancer in particular, there are two main types of breast cancer, depending on where they start within the breast tissue itself. So in the breast, there are things called lobules, which are glands that make breast milk. And so cancers that are starting there are called lobular cancers. Breast cancer can also start in an area of the breast that we call ducts, which are the channels that come out of these lobules and basically take the milk to the lobule, to the nipple. And so cancers that start here are called ductal carcinoma or ductal cancers. So it's important that we're sitting here today because Black women and breast cancer have a very complex relationship. So you always hear about the 1 in 8 chance of getting breast cancer, but we need to know that as Black women, our risk is particularly worse, depending on a lot of issues that I will not go into detail here about. You should know that despite all the advances we have in the screening and treatment of breast cancer, that Black women still have a 41% increased risk of dying of breast cancer. We tend to get breast cancer at a much younger age. We tend to have the breast cancers that are due to hereditary genes, even though nobody seems to talk about them or screen us for them. And when we do get breast cancers, we tend to have more aggressive tumors. So it's important to know what the signs of breast cancer are. And I love this chart, which comes from a website called Know Your Lemons. And it basically outlines the different clinical signs or symptoms that you may notice on your breast or on a friend or a family member. So I'm just going to go quickly over them. The breast dimpling, the peel of an orange on the breast, the thickening of any part of the breast tissue, any nipple changes like itchiness or a retracted or crusted nipple, discharge from a nipple, a red rash or sore on the breast, a vein that seems to be enlarging or popping out on the breast, or any change that you notice in the size, the shape, and weight of your breast. And then in some occasions, it could be an enlarged lymph node or gland that is in your armpit. As a radiologist, I do not want to see anyone coming with this sign, any of these signs. And so my focus here is going to be how to detect any of these signs of breast cancer or find cancer before it actually starts to show you signs or symptoms. Very important that you should know that breast cancer that's diagnosed in its earliest forms or stages has the highest survival rate, which is anywhere from 90 to 99% survival rate. This is where mammography, what I do, really comes in handy. So the earlier the breast cancer diagnosis, the better the treatment outcomes. Breast cancer, depending on where it is in your body, whether it's coming from the breast tissue or spread to distant parts of the body where we start to call it metastatic disease, is highly, highly variable on when you first detect the breast cancer. So for me as a radiologist, I want to see patients before they get out of that first rung of the ladder. And I like to see them when they're really at stage 0 or at worst at stage 1 at the bottom of the ladder. So screening mammograms are a tool to find the cancer early before you feel or see anything. It is the only imaging choice that has been shown to consistently reduce breast cancer related deaths, anywhere from 30 to 40%. And it is something all women should get starting annually at the age of 40, or might be earlier, depending on your family history. So it's really important for us as Black women to talk in the family. There are no secrets when it comes to breast cancer. We need to know our family history. So we need to know whether we're higher than the average risk of breast cancer. Because if you're somebody who has a high risk or has a family history, either based on what we call a calculated risk by genetic testing, you need to be getting your mammograms starting at age 30. And if you have risks additionally from getting chest radiation because you had lymphoma, sometimes earlier at age 25. Not only should you be getting mammograms, you should be getting a breast MRI starting at about 25 to 30 if you fall in this higher risk group. So the American College of Radiology, which I belong to, says you should be talking to your doctor, or you should be talking to your friends and family members, everybody, to ask their doctor to make sure that this risk assessment is done by age 30 to see if they require screening before that standard age of 40 that you hear everybody talking about. So what is actually involved in a screening mammogram? When we say screening, it usually means you're coming in without symptoms, no complaints. And my colleague, Hetty, is going to give a part B of this presentation going into further detail, but we typically take 2 pictures of your breast using the X-ray beam. And when these are done as a screening mammogram, I don't get to talk to you, but I read your mammogram and I send the results to you after a few days. So what happens after you get the mammogram? About 1 in 100 people, 90 of people in 100 will be told their mammograms are fine, and you're going to go home, get your letter, and return to business. So about 10 people out of that 100 will be asked in to come in for what we call a diagnostic mammogram. Out of that 10, 6 people will be again reassured that everything is fine. About 2 out of that 100 will be recommended to have a needle biopsy because there was something found that was suspicious. So it's also really important for you to know what I'm looking for when I'm looking at the mammogram. I'm not looking always for a mass or a lump, which is what people always think breast cancer is about. Breast cancer presents in many different ways on the mammogram. This is an example of what I'm looking for. Typically, I'm looking for calcium deposits, which are typically in the breast before a cancer actually forms a lump that a person can feel. So these are just various forms, and they're like salt deposits, so to speak, in the breast. And they look many different ways. But my job as a radiologist is to find this, because these are typically the earliest forms of breast cancer. But we're also looking for lumps inside the breast. And we're also looking at anything that can distort the breast tissue. This is where you'll see when you get your report that we start talking about your breast density. Your breast density matters. And I've just given you a nice schematic of what we mean when we talk about schematic. In the first picture, if your breast is mostly fat, it's easier for me as a radiologist to be able to see a mass in the breast. But as you can see, the denser and the less fat there is in the breast, the harder it is to see that mass or lump in the breast, because there's a masking effect. Not only does your density affect my ability to see the mass, the fact that you have more breast density also means that you have more breast tissue, and your risk of developing breast cancer is higher, about 2 to 4 times more than the person who has mostly fat in their breast. This is not in any way to encourage you to become more fatty, but this is probably the only time that fat is in your friend when it comes to detection of breast cancer. So the diagnostic mammogram that I talked about is after I look at the mammogram and I take a look and I see calcifications or any abnormalities, we call you back and we say to you, we need to do additional imaging. We also do diagnostic mammograms if you come to us after you've detected a clinical sign or symptom on your breast. So in this particular case, we focus our attention on one part of the breast, and we may actually do an ultrasound to examine that breast further. In this particular instance, unlike the screening mammogram, I, the radiologist, will speak to you, and we're mandated to speak to you by law before you leave the facility to let you know whether you're okay or whether you're going to need a biopsy. So I just included a picture of a patient who came in here with a lump in the breast. As you can see, the patient's breast is fat, which is the black thing you're seeing, and the mass or the cancer itself is white. So very easy to see white against a black background. After we do this, we go to the ultrasound and look focused in that area. And again, we see an appearance that is very suspicious for breast cancer. And in this particular case, I'm speaking to the woman and telling her she's going to need a biopsy. The biopsies are also performed by us in the radiology. So we will call you back schedule you, discuss the procedure with you, and it's all done under local anesthesia. So on the top corner, you're seeing a biopsy, which is being done using the ultrasound. And then this bottom right-hand corner, we use this to biopsy things that are not masses yet, like the calcifications, and this one is being done using the X-ray table. So when we get the biopsy results, we typically contact your primary care doctor, we talk to you, and in many institutions like myself, we help you to schedule the next team. So you're going to be hearing from the keynote speaker, who is a very crucial member of that treatment team. Typically, I see my patients year after year after year after this mammogram, and it gives me great joy because this is technology that's being used for good. So the key is early detection. If you don't know where to get screened, please go to this website, Love You Get Screened, if you're in the United States, and it's going to help you map to your local zip code to find a place where you can get free or affordable breast cancer screening. And with that, I am going to pause and thank you all so much for listening.
Dr. Kemi, thank you so much, Kemi, for this very informative and very complete and comprehensive discussion about what we need to do and why we need to screen for breast cancer. And I know that we'll take questions at the end, but what I gathered from what you're saying is that early detection is key. And I know that those of us here in the US and in the UK, I think, and we're programmed, because most of the time when you go see your primary care physician, the appointment sometimes is scheduled for you, or there's a reminder, especially if you go see your OBGYN. So we will talk later when we get to the Q&A about how best it is, what kind of reminders we should have so that we can, because we're so busy. Even though we know our health is so important, we're so always focused on our children, our parents, and our spouses. So hopefully when we go, as we go along, we'll be able to discuss, what are the best reminders and when we should be scheduling these tests. So we're very pleased to have our own Hobson, who is going to talk about screening. I have to say that every time I see on my calendar that it's time to get my mammogram, I panic because I think about what's going to happen. For those of us who have quite large breasts, let me say, because I'm in a hospital right now, so I can use that terminology, large breasts, we always worry about what this test is going to entail. So I'm hoping that our own sister, Miss Henrietta Okran of the HOPSA class of 1993 will put our fears, will make us not afraid as she explains what this is going to entail. So Miss Henrietta Okran is a HOPSA class of 1993 sister. She's a certified mammographer with a Center for Women's Imaging in New York. And we are so pleased to have her here with us today. And we're looking forward to hearing her tell us how the screening is done and what we should look forward to. Thank you, Henrietta, for joining us. And we can't wait to hear from you.
Hi, everyone. Okay, I'm Henrietta. So today we are going to talk about, I'm going to explain to you what to expect when you get to the mammo facility. Okay, so I'm a mammography technologist with Perlmutter Center for Women's Imaging of NYU Langone Health in New York. Can we have the next slide? Okay, mammography is an X-ray exam of the breast to diagnose breast cancer and other breast diseases. And it's performed by a certified mammographer. It has to be a certified mammographer. Mammograms are usually scheduled by patients with script from their primary care or OBGYN providers. When patients arrive, they are asked to replace clothing from waist up with a gown opening to the front. The technologist takes the patient into a mammography room, confirms the identity of the patient by asking your name, date of birth, and then the exam you were there to do. because sometimes patient is there to do one breast, both breasts. It's a screening mammo or diagnostic mammo. So it's confirmed with you to be sure that what you are there for, what your doctor scripts your doctor gave you matches what we have in the computer. Patients are advised before you come in, but we are also going to ask you when you come in. You are advised not to use deodorant or lotion and powder on the torso, and definitely no deodorant on underarm. The mammographer positions the patient. Of course, the exam is explained to you, so you know what to expect. The mammographer positions the patient on the patient's breast on the flat surface and compresses it with a paddle until the breast is taut. Then take an X-ray exposure, which takes few seconds to generate an image. The paddle releases automatically once the image is acquired. Minimum of 2 images, CC and MLO projections, are taken of each breast, one breast at a time. Once the mammographer is satisfied with the acquired images, the patient can leave the facility. It's that quick. The whole process takes few minutes and actually seconds for each breast to be imaged. The turnaround time for the results is 1 to 2 weeks, but normally it takes 24 to 24 hours for the result to reach you or your doctor. That is if you are doing stuff digitally. If it's being mailed, of course, it's going to take a lot of time, within a week. The images that the mammographer acquires are digitally transmitted to the picture archiving communication system, which we call PACS, where the radiologists carry out the diagnosis. Mammography Quality Standard Act, MQSA, implemented by FDA, is to emphasize high quality clinical imaging in mammography. In the US, mammo facilities are regulated and inspected regularly. The facilities have now standardized the 3D imaging instead of the obsolete 2D imaging. So you don't have to worry, everything is regulated and everyone there is professional and they know what they are doing. So you are in good hands going to get your mammogram done. Screening mammograms are quick, as I said, and that exam, screening mammogram exam, they are quick and that exam saves lives. So do not procrastinate any longer, as I've explained, it's really quick. And so I will end here and we will take the rest during the Q&A session.
Henrietta, thank you so much for that. It really put me at ease. And I think that it's always helpful when you have a friendly face there to do your mammogram. When I walk into the room and whoever it is says, welcome, and they have such a kind demeanor, I have to say it makes that experience so much better. So I'm so glad that you were there and that you're doing this service for women. So thank you for that. And I'm sure there are going to be lots of questions about what's the best way to get yourself comfortable and not afraid. And also, you know, when you get that call that you have to wait for further tests, what we should do. So there's so much that we need to ask you. So now we have a wonderful, wonderful, wonderful Hobson. I'm a little bit biased because I know her, and so forgive me if I gloat about her, but she is, now that we are getting older, we sometimes don't have class people that we know when we do these. So it's always so nice to see a familiar face. So this young lady, and she is young, is Miss Ifia Apia, and I feel as though I'm part of Ifia's family because I actually do know Ifia's brother and Ifia's sister, who is also a Hobson, and she is very dear to me. She's a member of the class of 1991 year group, and I know lots of you know her because Ifia is very active. Ifia, are you yellow print? I mean orange print, right? Exactly. So that was my print. So it tells you why I'm so fond of you. She is a social development expert with focus in the agriculture and public health sectors. She is also the current HOPSA Accra branch president. There are just so many things Ifia could have said about herself, but Ifia just does the work. She doesn't talk about what she does, but there's so much that Ifia has been doing for women in Ghana. Ifia actually helps to organize annual mammograms for sisters, for friends, for family members. And I'm going to let us hear her story from her own words, because she's such a great speaker. And so we're just so happy to have you here. And we thank you for accepting this invitation. And I know that what you're doing is going to benefit so many people. Without further ado, my little sister, my younger sister, Miss Ifiapia.
Thank you very much, Sister Jackie. And I definitely, it is my pleasure to be here. You know, I'm used to being very special, but I definitely don't think being that 2 out of 100 people who have a mammogram and are called back is the kind of special that I like to aspire to. But it's been interesting, to say the least, and I couldn't have done it alone. And I don't know whether I should call it a humbling experience, or I like to think I'm still going through the process of psychologically being diagnosed as having breast cancer. But of course, that's another discussion that will come up. But close to about 5-6 years ago, I started volunteering with the breast care team in Kolebu. And we are the ones who would go out, wear pink t-shirts, tell people to have their mammograms, go and get screening. We are walking through markets, you know, talking the talk and making sure that everybody is aware in October. And I'm constantly badgering people, my mates, they couldn't hear the end of it. And it was actually quite an eye-opener for me when I felt the lump in my breast. And I was just actually lying there. I looked through the slides of, Kemi slides of what the breast is supposed to look like. And believe me, there was nothing like that. It was just pure luck. It was just a miracle. And I felt something that felt different. That was it. It just felt different. And so I encourage people to, you know, just touch your breast, know what your breast feels like with all the usual lumps and everything. But if there's something different, you will be able to tell that there's something different. And thanks, because I was working with the Kolebu breast care team, I immediately, actually, when I felt the lump that day, I was like, hey, Asembeni, because my mother has 5 sisters. 2 of them were diagnosed with breast cancer. 1 passed away and 1 is still alive. So we have, as my cousins and I, and we're close to about 15 young ladies, we have this discussion and we are like, you know what, we have to be on the alert. We have to make sure we have mammograms. And my sister and I are the oldest set of all our cousins. So we're always pushing for this to happen. So I definitely knew it was just this, I was like, nah. And I went to UGMC and I had an ultrasound. And the gentleman was like, you know, he was very, very thorough. He did an ultrasound on both breasts and he was like, I see something here and I see something in your lymph node. So I lay there very quietly. I was like, who do I tell first? I got out of there and I called the breast surgeons at Kolebu and they were like, well, you know what you have to do. There's no waiting for this. Go and do a biopsy. And, you know, I always complain. I live in East Legon, and if I have to do anything in Kolebu, I always send someone. And I say, Kolebu, dear, quite wow. But believe me, I found myself in Kolebu from East Legon in under 30 minutes. I was there. You know, I'm always like, Kolebu is such a confusing place. I found the radiology department. I found the radiologist. I booked an appointment. And the next day, I was there to harass them. I was like, no, I have to have this image-guided biopsy. And what nobody tells you is the biopsy, they tell you, oh, it's just a needle, they'll put it in. But believe me, that needle, that little cane they used to numb the breast becomes like some 5 days old banku, hard. And then they try to get a true cut of the breast, of the tumor, so that you can take it to pathology for pathology to say, is it benign or is malignant? Is it cancerous or is not cancerous? And because they found 2 lumps, the gentleman had to do a biopsy of the 2 lumps. Luckily, it was very, very small. So after pathology came in. Of course, you know, I sent it to pathology, and I was on the phone like, can I have my results? Can I have my results? I don't think they were very happy with me because I was putting so much pressure on everyone to get my results ASAP. And when I got the results, I called the surgeons and they were like, okay, get these tests done, go and do blood work, go and do a CT scan, because a CT scan would take like 4 pictures of your body and see if the cancer has moved somewhere else. So of course, I did a CT scan in East Legon. Before I got home, it was like about 3 minutes, a 3-minute drive. Before I got home, I'm on the phone like, can I have my results? What does the CT scan say? And the lovely lady, Amy, was like, oh, I'll call you. I was like, but I want to know. So I got all my results and I went back to Kolebu and we sat down, and I must say, Dr. Dede, you know, when I talk about my breast care team, it's like we're at National Science, Maths and Science Quiz final, because Dr. Dede is a Gehe girl, an amazing woman. And she was with Dr. Johnson and Safo, who was from Infantsman. And so they sat there and they were like, girl, you know what you have to do? I was like, do you know what? Me, I don't want I don't want to go through this again. So as soon as we can do it, let's just cut off the breast and have treatment. And they were like, okay. So we sat there and they said, okay, we can't do anything. We have to link you to oncology. We have to link you to plastics. We have to link you to your care team. So the team was put together and we decided on the treatment plan. So the great thing I loved about my treatment plan was they involved me every step of the way. They made sure that I understood every single thing that was going to happen. But you know, I have to tell you this. My brother was adamant. They had a family meeting without me and they were like, you know what? Let's take her out of the country to go and do it. And that's the best way to go about it. And they came to me and they told me, I was like, please. And then I have the whole support team here. I have the best surgeons that I know of. I'd spoken to several people that Dr. Na, my oncologist, who is a Gehe girl too, I'd spoken with several people who she had taken through this process. And there was no way I was going to leave Ghana to do the treatment because it's just so critical. You know, I don't know if they were having meetings behind my back, but all my friends were, they were there for me. And I couldn't have done this without them. They were there for me. I'll wake up and Susan Edouard Mankwa will be in my bed. I would wake up and I have food in my kitchen. I didn't drive for the whole month of July, August. It was just amazing. And it made the process very, very manageable for me. And I thank God that I have a big fridge and deep freezer because I am stocked full of food. I think I have enough food till December or Christmas or maybe the new year, but it's critical. That care team is critical. My care team was from Ghana, with the US, with the UK. Everybody stepped in. Everybody stepped in to make sure that I was fine. You know, my phone rings, I'm like, Jesus, these people again. But they made sure that it was such a very coordinated effort. I'm yet to find out who was doing all the coordination, but it was very well coordinated. And it wasn't only my mates. You know, I remember when I went to do surgery, a gentleman walked in and he said, you know what, my wife says she can't come and look for you. So I'm here representing her and she wants you to know that she's thinking of you. I had people coming in and out of my room. The nurses were like, hey, what sister's Dawson? I'm sister's Dawson. But it was, I needed that kind of support because the surgeons will do their jobs, they will go away. There are going to be some times when you're lying there and you're thinking, is this really happening? And then a sister walks in and you have a little chat with her and she reassures you. You know, breast cancer, when they say 1 out of every 4 Black women or 1 out of every 8 women worldwide, there are a lot of women who have gone through this. And I don't know how they went through this without the kind of support, psychosocial support that I had, but I had a double mastectomy. They took out all my breast tissue and did reconstruction. After that, I had to wait a couple of weeks, 3 weeks, and I was put on chemotherapy for six sessions of chemotherapy. So once every 3 weeks, I go in and do an infusion. And you know, it's interesting, people are like, oh my God, you're doing chemo. And there's so much fear and stigma around having chemo, but you know, in all honesty, you go, they put in an IV line, and in my case, in 2.5 hours, I'm done, and I go and continue with my life. The science is so well developed now that you're given a lot of information. The side effects are controlled. The side effects are controlled, so you're able to, you know, there's not too much vomiting. There might be 1 or 2 points of nausea, but you have it controlled. The worst I've had is I had a whole night of diarrhea. But don't worry, Imodium works wonderfully. But it's a very, very controlled process. And the side effects are well managed, very well managed. And, you know, honestly, if I hadn't lost well, of course, losing your hair is one of the side effects, but I've been told that I've been rocking it. You know, I got myself some hoops, I got myself some very nice earrings. And, but, you know, it's very, very critical that you approach it with a very positive attitude, because, you know, if they say 1 in 8 women is going to get breast cancer in her lifetime, apart from the fact that you don't see visually a lot of women, you don't see breast cancer. That is the thing. You don't see breast cancer because a lot of women are wearing wigs. And I remember going into the chemo suite one day and everybody was like, with their wigs. I was the only one with no hair. I said, hey, wig. And, you know, it broke up the tension. Everybody laughed a little bit and we went back into our little cocoons of care. But you have to approach it with a very positive attitude. It's not easy, but it's doable. And financially, I know I've been asked several times, financially, it's an expensive process. And when we look at the data of women, especially in Ghana, not being able to go through care and treatment, sometimes finance is one of the key things that that they face, because at every step from diagnosis, before you get into treatment, then after treatment, it is a financial. There are some financial barriers, and if I always say that if we want to support the breast cancer journey, you start with diagnosis and support the person through, because it is definitely a challenge. So yes, So thank you very much. I would like to thank my support team. They have been very instrumental in making sure that I've kept my sanity. I've been I've had so much love, and I think I'll end with this. Along the journey, I've had so much support from HOPSAWs and their husbands and their friends and everything. But in my last chemo session, I was sitting there chatting with a lady, and I found out she was a HOPSAW. And it was like, we wanted to fall into each other's arms, but of course, with our IV lines, we couldn't do that. And we have kept contact. We call each other very often. She asked me, how are you doing? She actually, that was her last chemo session. So she calls to encourage me. I have 3 sessions left. And there was a lady, a radiologist who was also a HOPSAW, who was like, I'll just do your ECG for you. It's very painless. And HOPSAWs have been very, 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 very instrumental in this. And I can't thank them enough. So,
and we cannot thank you enough. We cannot thank you enough. This is incredible. Listening to you just tell a story, and something that scares so many people, including myself. And you being, when I listen to you, what I think about is how brave you are, even though you may not feel it. I think about how kind you are, how generous you are for sharing this, especially knowing in our culture, people don't, even as a physician, I ask my relatives, you were sick, what was happening? Nobody wants to talk about illness. And for you to sort of destigmatize this, we can't thank you enough. And there are going to be so many questions as we move on. But so thank you so much for being so brave, for being so articulate, for being so efficient in your description and making this come alive and making this seem like a normal conversation and not, there are no fears. I mean, people are so scared to talk about stuff like this. And so we're going to be hearing from you again. We're going to move on to an interlude. So if people need to if people need to get up and stretch their legs, or people need to feed a baby or feed a child, this is going to be the time. But we're also going to, as we do this little interlude, we're also going to hear from our sister, Sister Mary Arthur, who is HOPSAW class of 84. She's a professor and cardiothoracic anesthesiologist at the Medical College of Georgia. She's also the residency program director and the vice chair for education and faculty development. She works with HOPSAW USA Canada in the mentorship program. And Sister Mary is also one of my favorite sisters. She was a mass server in Holy Child, as I was. And I just remember how much I used to admire her when as she was doing all that mass server thing. And then I couldn't believe when it was my turn. And I realized that it wasn't by choice. Those nuns will get you if you don't get the flowers and the hymns and everything ready. So Sister Mary, we're so grateful that you are here with us, and we're going to open the floor for you to do this interlude for us. Thank you so much.
Oh, thank you so much, Jackie. You make me feel so special and holy, doing all that Mass 7 thing. Can you all hear me?
Yes.
So we have 126 people who have logged on. This is really, really, really exciting. And if you wouldn't mind, I'd like to share a screen with you and share a few things about, just give me 1 second, Share a little bit about our history of Holy Child, how we came about. So on October 13 in 1846, the Society of Holy Child Jesus was founded. And today we celebrate 176 years of this organization and the founding of a lot of Holy Child schools around the world, which have produced many women of substance. And a lot of those women are on this call today listening. Of course, we do have our sisters from Wesley Girls and our sisters from, is it Queen's College in Nigeria? Hope I got it right. So you're all welcome, and all the people who are joining us today. So in keeping with the vision of the Society of Holy Child Jesus, HOPSAW USA Canada which is a nonprofit organization, has instituted the e-mentorship program. We just had a session this morning with the students of Holy Child School, and it was very, very, very interactive and very, well attended and very inspiring as well. And it's basically to mentor and provide career guidance for students of Holy Child School. And today we're also partnering with Pink for Africa to bring awareness about breast cancer to everyone. So Pink for Africa, thank you so much for collaborating with HOPSA USA Canada for today. So for all of you online today, we're going to ask for your support and, really helping out with three very notable, things that we're doing. Your donations to HOPSA USA Canada will go to support the Sisters of the Holy Child Jesus. We're still in very close contact with our sisters. A lot of them were from the United States who actually helped educate us back in Ghana. And also for, the Sisters Worldwide. We also support Pink for Africa, which actually helps to bring about breast cancer awareness in the whole of Africa. And of course, if you want to, support the e-mentorship program, would really, really appreciate it as well. So you can send your donation via Zelle to hopsa.usa.canada@gmail.com, hopsa.usa.canada@gmail.com. And for those of you in the United States, and I believe in UK, all our donations are tax deductible. So please be generous. Thank you so much.
Thank you, Sister Mary. And I wasn't trying to flatter you, it was the truth. Everything I said was the truth about you. So thank you for being a role model for those of us who were behind you. Sister Becky is going to actually share a video now. And Sister Becky, Rebecca Liverpool, is a HOPSA class of 82. She is a HOPSA Canada leader, Canada USA leader. And I'm actually sitting in my chair, so excited because we will be introducing our keynote speaker in a few moments. And I am so excited. And actually in her honor, I think I did wear a little bit of purple. I have some yellow in my dress and I have some purple. And I hope that Queen's College is blue because I want to make sure that I represent appropriately. So let me talk about our keynote speaker who has been so gracious and so kind to join us this afternoon. Her name is Dr. Cynthia Owusu. She has an MD and also a Master's of Science degree. She is an associate professor at Case Western Reserve University School of Medicine, Department of Medicine, Division of Hematology and Oncology in Cleveland, Ohio. She's a breast oncologist as well as a geriatric oncologist at the University Hospital's Seidman Cancer Center, also in Cleveland, Ohio. She completed medical school in 1991 at the great KNUST School of Medical Sciences in Kumasi, Ghana, and completed clinical and research fellowships in hematology, oncology, and also geriatric oncology at Boston University Medical Center, Boston, Massachusetts. She also holds a master's in epidemiology from the Boston University School of Public Health. She joined the Case Western University School of Medicine in 2006. In addition to her clinical practice in breast cancer at the University Hospital Seidman Cancer Center in Cleveland, Ohio, Dr. Cynthia Owusu engages in clinical research that focuses on health outcomes and cancer health disparities. She is an investigator on multiple NIH grants, which is the National Institute of Health funded research grants, including the principal investigator on a $3 million research study. And this grant was awarded by the NIH on minority health and health disparities. This research study is examining the impact of exercise on functional health, body composition, and biomarkers of breast cancer prognosis among African American and socioeconomic status disadvantaged older breast cancer survivors. Dr. Owusu is a wonderful Wesley Girls High School alum. She's very proud of that. She's class of '82. She's married to a medical oncologist and she has 2 wonderful sons. She enjoys going to church. She enjoys participating in church activities, community outreach activities that cater to the needs of the underserved. And you can tell how happy I am that Holy Child and Wesley Girls are coming together to share the knowledge and the wealth. And this proves that we've always been sisters and we've actually always been close. So, Sister Becky, if you are ready with the video, I will pause here and we can watch the video and then we will go to our great sister from Wesley Girls High School.
This afternoon, I have with me Dr. Mary Arthur. I have 1 or 2 questions for Dr. Mary Arthur regarding breast cancer. Hi, Dr. Mary, how are you?
I'm doing well. Hi, Barbara. How are you?
I am well, thank you. I'm happy that you're here with me.
I'm so glad to be here too.
Okay. So according to the National Breast Cancer Organization, 1 in 8 women in the United States will be diagnosed with breast cancer. What does this mean to you?
So let's just take, bringing it home to what would typically happen on a normal day. If you're walking on the sidewalk, this means that for every 8 women that you see, it's very likely that woman will be diagnosed with breast cancer. Now, that's the sample size of the whole population. If you drill it down to women of West African origin, then that number gets more alarming. It could be 1 in 5, it could be 1 in 3, it could be 1 in 4. So for us, we are at a very high risk of being diagnosed with breast cancer. Fast forward Christmas 2021, I was one of those statistics. I got a phone call that I had an abnormal mammogram, and that led to a series of events, which today I'm glad to say I've had my surgery and I'm doing much, much better.
Now, based on what you know today regarding your diagnosis or what you know about breast cancer, what would you do differently? Or what would you advise people to do?
So being a very busy doctor, I was so busy taking care of other people that I wasn't taking care of myself. So I skipped my mammogram for a couple of years. But somehow last year, my primary care physician really insisted that I had it. So then I went in and I had my mammogram and I got the call. Luckily for me, going back and having done the mammogram again, going through the biopsy and going through the surgery, I had the good news that it was precancerous. Now, the issue here is that if I'd waited an extra year or 2, I couldn't have gotten the same results. So timely intervention was what actually saved me. And I wouldn't be here talking to you today if I hadn't gone through with my routine mammogram last year. So what I would advise everyone who's listening to us today, yes, life comes by, yes, we get busy, but remember that we have a duty for our family and our friends, and they need us to be around. So make sure that you get your annual mammograms, and do please take care of yourselves because we do need you around.
Thank you so much for sharing this with us, Dr. Arthur. Thank you for making the time. We're glad to have you around to share this information with us, and we'll see you again soon.
Thank you so much for having me.
You're welcome. Thank you. Bye-bye.
Just wanted to again thank you for accepting this invitation. You've shown that you're a true sister, and we can't thank you enough. So thank you for being here.
Okay, thank you so much. I want to express my sincere thanks and gratitude to the leadership of HOPSA USA and Canada, and to all of you for coming here today to listen to me. I think that sometimes we have all these artificial barriers, Wesley Girls versus Holy Child. I am truly honored to have gotten this invitation and to be in your midst. I was telling a story to the ladies that we've been working with that actually when I applied to Wesley Girls when I was young, I actually wanted to come to Holy Child, and my dad advised against that. So in spirit, I've always been part of you because I really loved your uniform, your yellow and brown uniform. Anyway, so I also want to thank those who have spoken before me, because they have really paved the way for me to be able to share with you what I have on breast cancer treatment options and prevention. I want to thank Dr. Kemi and Sister Hetty, because the story really begins from screening. I want to thank Sister Efia for her story. It's really amazing. And there's one key thing that she said: positive attitude. When you have a patient with a positive attitude, I tell you, all the work is done, because you need that positive attitude to be able to go through all the treatment. And if you don't have a positive attitude and you're fighting with everybody along the way, it doesn't usually end well. So Sister Efia, keep up the good spirit. So breast cancer treatment options and prevention. Okay, very good. I'm going to give you an outline of my presentation so that you can understand it as I move along. I'm first going to talk about the size of the problem of breast cancer in both the US and Ghana. Then I'll talk very briefly about the types of breast cancer, the stage and prognosis, which essentially we mean how does it affect your survival. I'll use a case presentation then to try and explain how your doctors arrive at the different treatment options, and then talk about the factors that influence that treatment decision making. And last but not the least, we will talk about some of the risk factors and whether we can prevent some of these risk factors. So what is the size of the problem in the US? This information is coming from the American Cancer Society and it's hot off the press. In 2022, this year, in the US, there will be an estimated almost 290,000 new breast cancer cases, and almost 43,000 women, unfortunately, are going to die from breast cancer. That translates every day to 790 new cases of breast cancer in the US every day, with 120 people dying. That's an awful lot of people to get breast cancer and to die from breast cancer. When you look at the number of deaths versus the number of new cases, it's about 15% of any woman in the US getting breast cancer, unfortunately, finally dying from breast cancer. Breast cancer is the leading cause of cancer in women in the US. This data, once again, is from the American Cancer Society. If you look here at female cancers, altogether in 2022, the highest number comes from breast cancer at 31%. It is also the second leading cause of death from cancer among females in the US. It's second to lung cancer. Now let's look at what happens in Ghana, the data from Ghana. This data is also very recent. It's from 2020. The source is Ghana GlobalCan 2020, and the data can be found at the World Health Organization's website. So in 2020, among all females, the number of women who had breast cancer was 4,482 from a total of 14,000. That represents 31%. That represents the leading cause of cancer among women in breast cancer. So in Ghana, so it's the number one cause of cancer among women in Ghana, breast cancer. The second leading cause is cervical cancer. So that's, I would just want to mention it, that could potentially be another topic for discussion because it's very closely following breast cancer. Now, when it comes to death, it's a different story between what we see in Ghana and the US. Of those women, 4,000 plus women who got breast cancer in Ghana, a little bit over 2,000 died. That is 50%. So in Ghana, unlike in the US, where we see 15% of the women dying from breast cancer once they get it, in Ghana, half of the women, unfortunately, are dying from breast cancer. And the reasons are multifactorial and likely will come up during the Q&A session. So moving on, so what is breast cancer and what is the difference between non-invasive and invasive breast cancer? These are terms that are thrown out there and kind of confuses everybody. And Dr. Kemi nicely went through how the breast looks like and so forth. So I'm going to be very brief here. I want you to focus on the ducts that come from the nipple, which is where once breast milk is made, it gets to the nipple, and that's how the milk comes out through the nipple. And these are the lobules. This is where milk is made. So these two structures, the lobules and the ducts, is where breast cancer develops. Now, this is a cross section of the duct. So just imagine that a knife has cut through this duct. What do you see? You see normal cells, or this is how a normal breast cancer duct should look like when you look at it under the microscope. For a variety of reasons, many of which are unknown, in some women, they begin to make extra cells out of control, cannot be stopped. And these cells begin to accumulate inside the duct. Note that none of these cells have gone out. This is what we call ductal carcinoma in situ, or the precancerous lesion that Dr. Arthur was talking about. This is non-invasive. It is breast cancer, but it's non-invasive because it hasn't made it out here. But if you leave it alone, do not take it out, it's going to make it out. And once it invades through and breaks through the cell's perimeter, voila, you have invasive breast cancer. These cells can grow completely out of control, and it has only one goal: to take over your entire body if you're going to allow it. It will spread through the lymph nodes, then get to your bloodstream, then start growing, potentially could grow in your brain, in your bone. And so it's got to be taken out before it has a chance to do that. Now, with this slide, I wanted to show you the link between the stages of breast cancer and prognosis, the impact on your survival. Dr. Kemi told us the stages of breast cancer, which is 1, 2, 3, and 4. Here, a different terminology is being used by the American Cancer Society. They use localized to represent stages 1 and 2. They use regional to represent stage 3, and then distant to represent stage 4. This looks complicated, but I'm going to break it down. So this slide is looking at 5-year relative breast cancer survival rates by stage at diagnosis and by race. And that's what I want to show you here. So the pink bar represents the white women who had breast cancer, the lighter pink African American, the gray hair American Indians, and so forth and so forth. I want you to pay attention to these two bars here. So this group of bars here is looking at all stages, all women who had breast cancer between 2012 to 2018. What was their 5-year survival? We place emphasis on 5-year survival because that's the time that if you are most likely to get a recurrence from breast cancer, that's when it's likely to occur. So a lot of our data focuses on 5-year survival. And you can see the good news here is that 5-year survival rates are in the 90% range. That's the good news. What is the bad news? These are the African Americans. They have the lowest survival rate. When you look at it by stages, you can see that for the localized stage 1 to 2, yes, African Americans have the lowest survival rate, but the difference isn't much. The difference begins to space out as the stages increase. And by the time you get to stage 4, a significant proportion of African Americans tend to be more likely to die of their breast cancer than their white counterparts. And many, many reasons account for that. With this slide, I'm trying to emphasize the same point because sometimes certain factors are so important that you've got to keep repeating it. So this slide is coming from the American Cancer Society, and it's examining the trend in mortality rate in women who have breast cancer in the US from 1975 through to 2020, and this was just released. There are two important things that you can see, and they are looking at this by race. And once again, I want you to focus on these two curves. These represent the Black women and these are the white women. What you can see is that over the years, mortality rate is getting lower, and that's very good news, and that's for both racial groups. And that has been actually attributed to early screening, advancements in technology and treatment, and also less women using hormone replacement therapy. But what you see is a persistent gap, decade after decade, between Black and white women, translating to a 43% higher risk of death for Black women compared with whites. What do the authors of this publication say? And I'm going to quote her because I don't think I can report it in any better way than, or say it in any better way than she said it. She said, "We've been reporting this disparity," and that's the Black-white disparity, year after year for a decade. The differences in death rates are not explained by Black women having more aggressive breast cancers. It is time for health systems to take a hard look at how they are caring differently for Black women. And that, I'm afraid, is the reason for the poorer outcomes in our Black women with breast cancer compared with their white counterparts. So moving right ahead, I'm going to go into treatment of breast cancer, and I'm going to start it with a case presentation so that it makes it easier for you to appreciate and understand. So we have Akosia. She's a 50-year-old premenopausal woman. And by the way, anything I say here, a lot of the things I'm saying here, some clinical implications, which I'll explain as we go along. So Akosia is a 50-year-old premenopausal woman. She self-palpated a left breast lump. She then underwent breast imaging with a mammogram and ultrasound, which revealed a 5.1 centimeter left breast mass, and that's what we see here. She also had multiple abnormal lymph nodes in her armpit. After that, as Dr. Kemi explained, she needed to undergo an ultrasound-guided core needle biopsy. pathology results came, and the results were consistent with infiltrating ductal carcinoma, otherwise breast cancer. Grade 2, it was estrogen receptor positive, progesterone receptor positive, it was HER2/neu positive, and that lymph node biopsy was also positive for breast cancer. Her stage is stage 3. And she's asking you, Doc, what are my treatment options? So what are the treatment options for early stage breast cancer? I'm going to say here that the treatment that we're going to be discussing today is for stage 1, stage 2, and stage 3 breast cancer. Stage 4 breast cancer is not included because that's an entirely whole new topic, which will take us another 1 hour. So we're doing stage 1, stage 2, stage 3, considered early stage breast cancer. So there are many treatment options. It starts off with surgery. We also have radiation. And then there's a role for chemotherapy for some women, as we just heard from Ithia. We have hormonal therapy for some women, and then we have targeted therapy as well as immunotherapy. So when do we decide to do what? Localized therapy. The only treatment that's going to cure you of your breast cancer is surgery. If you do not get your surgery removed, it doesn't matter that we gave you chemotherapy or hormonal therapy and the mass disappeared. You're not cured. So every woman, as standard of care, will be getting surgery. Not everybody gets radiation therapy, and I'll explain that as we go along. So what are the differences or the options as far as surgery is concerned? You either typically get what we call a lumpectomy, which is simply removing the area where your breast cancer is and leaving your breast intact, or you get a mastectomy where your whole breast is removed. I want to emphasize here that if you do a lumpectomy and you get radiation, it has been proven in study after study that it provides equivalent survival benefit as mastectomy. So usually there's no reason why you should opt to do a mastectomy if you are a candidate for lumpectomy and you're willing to do radiation. Sometimes you are not a candidate for mastectomy. Sometimes too, it's patient's preference. If the patient wants a mastectomy, the surgeon is going to do it. So sentinel lymph node mapping, that's another procedure that goes along with whether you do, if you do a lumpectomy. If you do a mastectomy, the lymph nodes are coming out automatically, so they do not usually bother with that. Why is sentinel lymph node mapping important? Remember, I told you that you have these lymph nodes in your axilla. They act as the bodyguard, as the gatekeeper. If you have a lump in your breast, the breast cancer cells are going to want to escape to the rest of your body. Their pathway to the rest of your body includes spreading first to these lymph nodes, overcoming the bodyguards, and then they enter your lymphatic system and spread, or enter your bloodstream and spread. So once you have breast cancer and you're going to get surgery, it is important for the surgeon to know whether the gatekeepers have been overcome, because if they have been overcome, then it means that perhaps some of the cancer cells have already escaped into your bloodstream, and therefore your treatment ought to be much more aggressive than the woman whose lymph nodes didn't show any evidence of cancer. At the same time, it's impossible for the surgeon to go in and remove all of these lymph nodes. In fact, they will leave you with a condition we call lymphedema, where your arm swells up. It's almost impossible to use. It's very painful. So they just want enough information to know whether your lymph nodes are positive or not. So the first thing they do during surgery, or one of the things they do, is to inject this blue dye near the cancer cell, the lung. And the rationale behind that is that when they do that, the blue dye is going to go to what they call the sentinel node. Similarly, they expect that if cancer cells were escaping, they would have gone to the sentinel node. So in the OR, they'll take the sentinel node out, quickly look at it under the microscope to see whether you have cancer cells in them. And if you do, then they'll go ahead and do a little bit more extensive, what we call axillary node dissection. Otherwise, if these sentinel nodes are negative, that is it. They don't explore any more lymph nodes. So that is it for sentinel lymph node mapping. The other thing that's important regarding surgery is what we call negative or clear margins. The surgeon is going to go in there, he's going to try to take out all the cancer in your breast. And the way we know he's been successful is that if he has normal, healthy tissue surrounding the cancer that he took out. So when he takes out or he does the lumpectomy, the pathologist is going to examine the edge here. And if there's a healthy distance and a healthy margin, meaning normal tissue, you are cleared. You're going to be told that you have negative or clear margins. You don't need any further surgery. Unfortunately, if some of the cancer cell is seen at the margin of the specimen, it means that perhaps there was more cancer left behind. You unfortunately have to go for a second surgery called re-excision in order to achieve what we call clear margins. Once you have clear margin, the assumption, and for the most part is right, it means all the cancer has been taken out of your breast. Well, that is not the end of the story. Even though all the cancer has been taken out of your breast, it is always possible that microscopic breast cancer cells could have been left behind. We do not have any machines, we do not have any technology, no human being, no pathologist can be able to identify these microscopic cells. And so there comes in what we call adjuvant treatment, additional treatment to kill off any microscopic cancer cells that could have been left in the surgical bed or may have even traveled through your blood. So one of the treatments or one of the treatment options is radiation therapy. It is necessary to do that when you do a lumpectomy, because remember, with lumpectomy, you're only removing that part that contained cancer. So you have a higher chance that some of the cancer could have been left behind no matter what the pathologist said. And so radiation it's actually very easy. You lay on a table, as we see in this picture, the machine then directs radiation towards your breast and into your axilla as well. They do radiate your axilla, trying to kill off any cancer cells. And it can reduce the risk of your cancer growing back in that breast by 50%. When we say that is assuming that over a period of 5 years, you have a 10-fold risk of you getting a recurrence, a local recurrence. 50% means that it's going to cut that number 10 down to 5, leaving you with a recurrence risk of 5. So that's what we mean by a 50-fold risk reduction. Radiation is quite protracted. It used to be 5 to 6 weeks. These days, due to better technology, radiation is being done on average 3 to 4 weeks, and we even have better technology. And I just wanted to draw your attention to one of those. It's called accelerated partial breast radiation, which only takes 1 week. So this is your normal or regular radiation, external beam radiation. The yellow is representing where the radiation is going to fall in your body. Here is the human heart here. And so you can even see that part of the radiation is in the path of, your heart is in the path of radiation as well. This is the surgical cavity. And so that brings in some of the side effects of radiation. Potentially down the line, you could have what we call cardiac toxicity or congestive heart failure, for example. With the newer techniques, radiation is very precise. It's almost, if you can see, superimposed on the surgical cavity right here. It doesn't even fall on some of the other breast tissue. Everything in blue is breast tissue. Some of the breast tissue is spared, and the heart is certainly spared. And so with the newer technology, radiation is getting easier and easier for women with breast cancer. So now we finished talking about localized treatment for early stage breast cancer. We're going to go to what we call systemic treatment, treatment that goes beyond the regional area, the area of the breast and your axilla. This is treatment that's going to travel through your blood and try and kill off any potential cancer cells that may have escaped, that if left alone down the line, several years, and it could be 5 years, it could be 10 years sometimes, it could even be 20 years, it can start growing and give you stage 4 breast cancer. So that's where chemotherapy comes in. We also have another treatment called targeted therapy, also known as HER2-directed therapy. Some women need to get immunotherapy, and then some women need to get what we call hormonal therapy. These are pills. Chemotherapy, HER2-directed therapy, immunotherapy are all IV medications. So what determines who gets what treatment? Before we can do that, we need to talk about breast cancer receptors. So receptors are molecules that sit on a surface of a cell, okay? So if you look at this, this is an estrogen receptor. It is sitting on the surface of the cell and signaling to the cell to turn certain functions on and off. So for most breast cancer cells, you have estrogen receptors sitting here. When estrogen is produced, it latches itself onto the receptor. Then what the complex does is to send a message to the center of the cell, the nucleus, and tell the cell, produce cells in an uncontrolled fashion, non-stop. And very quickly, you see a lump. So that is the significance of receptors. And there are 3 main receptors that every breast cancer patient gets tested for: estrogen, progesterone, and HER2. And I'm going to talk briefly about them. So what proportion of our patients have estrogen or progesterone receptor positive breast cancer? Meaning when they tested their breast cancer, these were the receptors that were seen. Majority, 72%. The good news is that hormone receptor positive breast cancer is the least aggressive form of breast cancer. It is what we call a little indolent, plus it can be treated with hormonal therapy, which is a pill, which comes with less side effects and is very easy to tolerate. The second group of people have what we call HER2 positive breast cancer, 15%. HER2 stands for human epidermal receptor growth factor. Think of it as a protein, think of it as a growth factor, think of it as a fertilizer, which is being poured on the cell and has cranked the cell up. And this cell, which already is cancerous and was growing out of control, is now growing out of control times maybe 5, 6. So that's the significance of having HER2 new positive breast cancer. And a minority of women have that. The last group of people have what we call triple negative. This means that when we tested them, they neither had estrogen receptors, they didn't have progesterone receptors, and they didn't have the HER2/neu receptor as well. And I'm sure somebody will say, "Way, good, that is good news." Unfortunately, that is bad news. That is the most aggressive form of breast cancer because it doesn't need anything to grow. It doesn't need estrogen. It doesn't need progesterone. It doesn't need a growth factor. It is autonomic or automatic, sorry. It just grows. You can use a pill to treat it or to kill the cancer cells. You can use HER2/neu directed therapy, which is one of the most effective treatments we have in breast cancer, to kill it. The only thing you have that you can give to these women, unfortunately, is chemotherapy. The good news is that this is the group of women that immunotherapy has now been discovered to be effective. So now they get chemotherapy and immunotherapy. So that's how we use receptors to decide who gets what treatment. A patient could be getting both the HER2/neu directed therapy and still be hormone positive as well. So they will get hormonal therapy. Triple negative is what it is. None of them are positive. So the only thing you can get is chemo or immunotherapy. Now, I wanted you to see what's happening or the profile of our Ghanaian women, because the story there is not very good. As I just mentioned, triple negative breast cancer is the most aggressive form of breast cancer. This graph comes from a study that was done in 2010. It was a collaborative study between researchers from University of Michigan and researchers from Ghana, University of Science and Technology. And what they did is to gather breast cancer specimens from women in Ghana, Confanochi, and send them over to the US. And they compared their pathology and their receptors with white women and also with African American women here. And what do we see? What proportion of white women had triple negative? It was 15%. What proportion of African Americans had triple negative breast cancer? It was much higher, it was 47%. Ghanaian women, 83.3%. Majority of the women had the most aggressive form of breast cancer, which is very difficult to treat. I have done a literature search to look at other studies. I just didn't report it. And frankly, the lowest proportion I saw was 50% in one study. So it is, for some reason, our fellow Ghanaian women tend to have triple negative breast cancer much more often than their African American and white counterparts, and it has treatment implications. So how do we use these receptors and other factors to influence breast cancer treatment? I think I've been mentioning it as I've been going along. If you have triple negative breast cancer, it means for the additional treatment, you're going to be getting chemo and immunotherapy. If you have HER2/neu positive breast cancer, you're going to be getting the HER2 treatment, but chemo has to be added to it because by itself, it won't work well. If you have hormone positive breast cancer, then you're going to be getting hormonal therapy, which is the easiest one, and it's a pill. But there are other influencing factors that might make your doctor decide to add chemotherapy to hormonal therapy. And some of these factors are age. Younger women tend to have more aggressive treatments. Physicians are very careful about women who are young. A young woman shouldn't be getting breast cancer. A young woman has a long life expectancy for breast cancer to be able to rear its head up maybe 20 years later. So we tend to be a little bit more aggressive. Premenopausal women who are still having their menses, we tend to treat them more aggressive. They tend to benefit even better from chemotherapy. If you have nodal involvement, that gatekeeper, if that gatekeeper has been overcome by cancer, that's a problem. We tend to treat you more aggressively. And then we have we call genomic assays, and I'm going to explain that in the next slide. That is really personalized medicine in a sense. In the past, we had to use our clinical judgment if somebody was hormone positive to decide, okay, I want to give this person chemotherapy. I'm going to look at her age. I'm going to look at how big her cancer is. Now we don't have to guess anymore. We have genomic assays to tell us who benefit from chemotherapy, and then we decide and we add that. So this is an example of a genomic assay. It is the most well-established one currently in practice. It's called the Oncotype, and essentially what it is that researchers have already identified 21 bad actors or 21 genes that could occur in anyone's breast cancer. When you have breast cancer, we take a piece of your breast cancer and send it to Genomic Health. They are going to look and see how many of those 21 bad actors are you expressing in your breast cancer. Remember, I talked about Akosia. So Akosia, how many of these genes did Akosia have? Depending on how many Akosia had, it's translated to what we call the recurrence score. And that's what we see here as 10. That by itself is meaningless to everybody. So they go on and translate that score to something that is real. Over a period of 10 years, what is the likelihood of Akosia, for example, who has a score of 10, having a distant recurrence? Distant recurrence means that you went for perhaps stage 1 to stage 4. And for somebody who had a score of 10, has translated to a 12% risk. And that is considered very good. The assay also goes on to tell us whether such a person would benefit from chemotherapy. And it tells us clearly here that there's no apparent benefit from chemotherapy. So with these results, then you decide that the only additional treatment you're going to give this patient is hormonal therapy, and the patient doesn't need chemotherapy. These assays have been critically important in allowing us to de-escalate, because as you just heard, chemotherapy does have quite a few side effects. So being able to identify who really needs it and giving them chemotherapy is very helpful, so that those who don't need it can avoid getting chemotherapy and its bad side effects. Okay, so the what, when, and why of chemotherapy. I think I've already mentioned why we give chemotherapy. We give chemotherapy because we want to go and after those microscopic cancer cells that nobody can see, so that they don't get a chance to grow in future. Chemotherapy, as Ms. Efia described, can actually be a very pleasant experience. So here I'm just showing you how some of the chemotherapy infusion suites look like. They really try to make the environment very pleasant. For the most part, you'll be sitting in a couch and it's given, this is an IV bag here if you can see it, and it's given intravenously. Sometimes it's given by IV push. You get your chemotherapy, you are there depending on what kind of chemotherapy from about 2 to 4 hours, and then you go home, and then you come back when your next treatment is due. And we do give you a lot of medications to counteract the side effects. Chemotherapy reduces the risk of recurrence by about 30 to 40%. Okay, so who should receive the targeted therapy that I mentioned, the HER2/neu directed therapy and immunotherapy? I think I've mentioned that already. Women with HER2/neu positive breast cancer should get targeted therapy. We have 2 drugs, Herceptin and Perjeta. It reduces the risk of recurrence by 50%. You see that it's even higher than when you give chemotherapy alone. This is a very effective regimen for HER2/neu positive breast cancer, and every woman with HER2/neu positive breast cancer, so long as the mass is bigger than 6 centimeters or larger, should be getting some HER2/neu directed therapy. It is curing women. How about women with triple negative breast cancer? I told you that we now can give them immunotherapy in addition to chemotherapy. Typically, these two treatments are actually given before surgery, and I haven't mentioned that thus far. So we have treatment that we give after surgery for the most part, and that's what most people do. They get their chemo after surgery, or these targeted therapies, they could get them after surgery. That's adjuvant. Sometimes your doctors decide that your breast cancer is too big. We need to shrink it down so that when we go to surgery, we can get those clear margins. In those women, we give your chemotherapy or immunotherapy or HER2-directed therapy before surgery. Once you get your chemotherapy, you don't come back in the adjuvant setting and get it again. You get it just once. For women with triple negative breast cancer, as you can imagine, it's aggressive. They typically present with large masses, so they do get this treatment before surgery. And it is effective. It can achieve complete disappearance of breast cancer cells in 60% of cases. So by the time you get to surgery, the breast cancer is gone. I'm not necessarily saying you're cured, but it's gone. They can't find it. What they normally would do is that they're going to put what we call markers, so they know where your cancer is. You go and get your chemotherapy. When you come, even if they can't find any cancer left, they know where those markers are, and they go and they cut out that area. And in 60% of cases, the cancer can no longer be found when you get immunotherapy with chemotherapy for triple negative breast cancer. So moving on to hormonal therapy. I've already mentioned that women who have estrogen and progesterone positive breast cancer should receive hormonal therapy. And we have two options. We have tamoxifen and aromatase inhibitors. I'm going to try and walk you through this figure. It looks complicated, but it's really simple. And I'm trying to show you how these two drugs work and when who gets what. So we have this enzyme which acts on these substances to convert them to estrogen in a woman's body. Aromatase inhibitors, which are the newer, more effective drug, block or neutralize this enzyme. Essentially, they shut the factory down. They shut the production of estrogen. Remember, estrogen is trying to get to the nucleus of the cell and crank it up. So by giving a woman an aromatase inhibitor, you're shutting the production of estrogen down. That's the good news. The bad news is that it cannot shut the factory down in the ovaries. You produce estrogens from so many different parts of your body, and it's able to shut it down everywhere else except the ovaries. So that brings the significance of somebody who's premenopausal versus postmenopausal. If a woman is premenopausal, it means her ovaries are active. If you give her an aromatase inhibitor, it's useless. It's not going to be able to shut the ovaries down, and she will continue to produce estrogen from the ovaries, and that will continue to activate the cell and make it continue to produce cancerous cells. So for that premenopausal woman, the drug of choice is tamoxifen. What tamoxifen does differently is that instead of shutting the factory down, it occupies that receptor. This is estrogen. It needs to come and bind itself to this receptor and then instruct the nucleus to make cancer cells. If tamoxifen is sitting here and sitting here and sitting here, when estrogen comes, there's no room for it to attach itself to the receptor. And so the end result is the same. The end result is that the cancer cell does not get that signal that it needs, and the breast cancer cell cannot replicate. And so tamoxifen is the drug that we give to premenopausal women because they have an active ovary, unless we decide that their breast cancer is so high risk that we need to go take her ovaries out, or we need to give her an additional injection to suppress or shut the ovaries down so that she can get the better pill, aromatase inhibitor. tens of thousands, studies after studies have shown that aromatase inhibitors are more effective in preventing breast cancer recurrence than tamoxifen. But I want to emphasize that tamoxifen is a very good drug yet still, and we use it all the time for premenopausal women. So now we are back to Akosua. We want to see what treatment Akosua did actually receive. Remember, I said Akosua was 50 years old. I said she was premenopausal. I said she had a 5.1 centimeter mass. I said she had abnormal lymph nodes. And I said she was estrogen and progesterone positive, and she was HER2 positive. So what treatment did her doctors give her? She actually got chemotherapy before surgery because she has HER2 new positive breast cancer. It was a big cancer. It needed to be shrunk down before she went to surgery. So she got 18 weeks of the HER2 new treatment plus chemotherapy. After chemotherapy, she had a mastectomy. Akosua's destiny regarding mastectomy was already declared by the fact that her breast cancer was 5.1 centimeter. Any woman who has a breast cancer that is larger than 5 centimeters, the standard of care is a mastectomy, because we are scared that we're going to be leaving breast cancer cells behind. She did have reconstruction. Akosua went ahead and also got radiation. Somebody will ask, but she got mastectomy, she didn't get lumpectomy. Why is she getting radiation? Once again, that 5.1 centimeter mass, there's a high likelihood that microscopic cancer cells could be left behind. So that's an indication to have radiation therapy, even if you have mastectomy. Akosua then went on and had hormonal therapy, because remember I said she was estrogen receptor positive, but because she has an aggressive breast cancer, we suppressed her ovaries and gave her an aromatase inhibitor, which is the more superior treatment. And then she continued on maintenance HER2 treatment. This is given for a year. So once you finish surgery, we drop the chemotherapy, which is the TNC, and you just keep getting your HMP continuously every 3 weeks for up to a year. So that completes the range of treatment that Akosua received based on her breast cancer. So now we're going to transition to breast cancer risk reduction and preventive strategies. What is a risk factor? A risk factor is anything that increases your chance of getting a disease. Remember, having a risk factor or even many does not mean that you are sure to get breast cancer. It does not also mean that it's the cause of your breast cancer. We really don't know the cause of breast cancer. If we knew the cause of breast cancer, there would be a magic pill which would prevent all of us from getting breast cancer. So it's unclear why one woman who has a set of risk factors never gets breast cancer, and another woman who has the same risk factors that does end up developing breast cancer. So there are many factors that remain unknown, but suffice it to say that we know that if you have these risk factors, you should be a little careful, and it's concerning. So some of these risk factors are modifiable, and others you cannot do anything about them. So which ones can't you do anything about? Being born female is actually your biggest risk factor for breast cancer. You can't do anything about it. Getting older, as you get older, for some strange reasons, you develop what we call mutations, and it causes your breast cancer cells to just keep growing in an uncontrolled fashion. When you inherit certain gene changes, and I think Dr. Kenny mentioned that BRCA gene, I'm sure you've all heard about it. 10% of all breast cancers are because of inherited genes. If you have a family history of breast cancer, particularly if the family members were younger, sometimes it means you actually do have carried that gene, but you may not have been tested. And so those women tend to have a higher likelihood of having breast cancer. If you've had one breast cancer, you have a higher likelihood of getting another breast cancer. Race and ethnicity, that is very interesting. Did you know that breast cancer incidence It's actually higher in whites than in blacks. So white women are more likely to be diagnosed with breast cancer. However, Black women are more likely to die from it. So that's really what the facts, and sometimes we mix up the two. So some white women are more likely to get breast cancer. They are just not dying from it as often and as quickly as Black women. Dense breast tissue, Dr. Kinney mentioned it, so I won't belabor that point. When you have certain benign breast conditions, so you had a lump, they took it out, it was benign, some people have had 3, 4, all those things can place you at increased risk for breast cancer, or it's been noticed that those women sometimes eventually end up actually having a real breast cancer. Then issues with menstrual periods, so starting your menstrual periods early, going through menopause much later, that is all related to your exposure to estrogen. So if you get your menses early, you're making more estrogen. If you have your menopause late, it means that you lived longer with exposure to estrogen. Anything that's increasing estrogen exposure can increase your risk. So that's where that comes in. And then having radiation to your chest several years later could cause another breast cancer. So what are some of the modifiable risk factors, things that you can do something about? Alcohol. Alcohol has been shown to increase your risk for breast cancer. The length of the duration or the length of time that you've drank alcohol and how much you drink alcohol, they're all directly related to your risk. So we need to watch it and try and curtail that. Being overweight and obese is linked to breast cancer through estrogen. Not being physically active is another one. So exercise, exercise, exercise. Not having children. Sometimes you can't do anything about it. Unfortunately, you've tried everything and you couldn't have children. That's different. There are people who decide, I'm not having children. When you get pregnant, your period ceases, right? So that's a period where there's low estrogen in your system, and that is protective. And that's why women who've never had children are more likely to get breast cancer. Not breastfeeding. You have a child, you are breastfeeding, you realize that your periods take several months, sometimes a year and even more for your periods to return. That's how breastfeeding protects you from breast cancer. Birth control pills, we all know, can increase your risk of breast cancer. Then menopausal hormone therapy. So this is giving somebody estrogen, and it used to be a very common practice until a huge study came back and showed that it increases breast cancer. And these days, when women go into menopause and they have hot flashes, doctors are no longer eager to give them hormone replacement because of the risk.
Yeah, I'm going to just segue here in a little bit, just because these what you're talking about are the questions we're seeing that are coming to our chat. And so hopefully, I'm wondering if we can start sharing them, because unless, since you're answering so many of them, and I was hoping that we can perhaps start asking some of the questions that we're receiving in the chat. What do you think? I don't know if you are.
I have just about 2 more slides.
Yes. Absolutely.
Okay, so if I can just finish the 2 and then we'll be done. I might just skip a couple. There are some risk factors that we don't have enough information on. Interestingly, diet and vitamins, the data does not show one way or the other, so that's an unknown. It's important for colorectal cancer, but breast cancer, we don't know that diet or vitamins are risk factors. Chemicals, we don't know that either. Smoking, we don't know that either. Night shift, there were some questions about it, but that one too, the studies haven't panned out. Then there are disproven risk factors, and one of them is deodorant, and I get that from my patients all the time. The belief is that deodorants cause obstruction of the lymphatic vessels. That has been disproven. No link to breast cancer. Bra, the same thing. It causes, people think it causes obstruction to the lymphatics, and that has also been disproven. And abortions. I'm going to skip this and go to this last but one slide. I just want you to know, as I end, I want you to know that up to 30% of breast cancer may be preventable with simple changes in your lifestyle, according to American Cancer Society. And what are these 3 things? Maintaining normal body weight, avoiding physical inactivity, and avoiding or limiting alcohol intake. Thank you, and we'll be very happy to take any questions that you have.
Oh my goodness, Dr. Cynthia Owusu, this is incredible. You've given us a lecture, a talk that we will remember for a lifetime. I know that the panelists, including you, excuse me, as you were speaking, I could just see people keep it writing in their calendar to remind themselves to schedule their mammograms. I know that you went into this field, all of us, to do good. And today I want to say that the panelists and the people, the audience, you guys have done good. You have done such a good deed. I've learned so much just listening to your words of wisdom, just sort of meticulously going through everything and not making me scared, as all of you described how we can all prevent, or if we have breast cancer, how this can be cured and how we shouldn't be scared and how we shouldn't feel alone. I'm so grateful. And I was going to invite the panelists, all of us, those who are here as special panelists. But before I do that, we have another speaker who has been so gracious to join us. It's my pleasure to introduce Mrs. Juliet Mills-Luttrell. And I think I actually know Juliet, but our paths haven't crossed in so many years. And I also think her last name is different, but I'm not sure. But Dr. Juliet, Mrs. Juliet, who goes by Jules, is a mother. I love mothers. She's a wife. She's a director of a group of her own companies. After she survived breast cancer and chemotherapy treatments, Mrs. Juliet Mills-Luttrell, an industrious personality, has redefined innovation and ambition to keep raising the bar as a self-made successful businesswoman. She is an entrepreneur, as well as a hairstylist whose integration of her own brand name has changed the way the world reckons the act of survival. Her Jewels collection label, an idea which was inspired by her chemotherapy treatment, manufactures exquisite-looking Italian leather handbags with a blend of a multicultural look and feel to them. A percentage of all proceeds from these precious and immaculate handbags go towards her breast cancer foundation, Pink for Africa. The foundation creates public awareness and educates women on risk factors, symptoms, diagnoses, treatment, support systems, stigma, and I'm going to say again, stigma, and the need for a positive attitude. She is the director for Pink for Africa and the visionary and overseer of the organization.
Thank you so much. Thank you so much. Thanks for the beautiful introduction as well. Thank you. My name is Juliet Mills-Luttrell, founder of Pink for Africa. Like the bio said, I am a mother, I am a wife, I'm a sister, and I run my own businesses. At the peak of my career, I was diagnosed with breast cancer, and this is what has brought me here. I've been in remission for 14 years, and I can honestly and confidently tell you, breast cancer was the best thing that ever happened to me. And I say that to mean quite a few things. One, my value for life and value for enjoying the moment and appreciating why I'm here is elevated because of my diagnosis and since my diagnosis. But one thing I cannot stress enough about is all through this month, doctors are around, nurses are talking, advocates are talking, and everybody leads to early detection. I am in Ghana now, and I've been, since I landed on the 2nd, I have literally haven't had much sleep. I've been on ground, working hard. We spent a week in Ho, and the oncology department opened up. The whole hospital recently opened up an oncology department, and we wanted to be a part of that. And through education in the outskirts of Ho and also in the schools, we realized the importance of reaching outside of Accra. And so much is done within Accra, but very few of the screaming and the awareness reaches outside of Accra. So our efforts is to push beyond Accra and build relationships. And we just connected with Tamale Hospital as well. We're going to be doing some donations for them and encouraging women. For the next 2 years, Pink for Africa's mission is to focus on early detection by encouraging the woman to come forward when they've been through their first mammography and something is found. If they are afraid to get tested because they cannot afford it financially, we can be there as an organization to pay for that and get them in, and then we can continue the journey with them. We partner up sometimes with different organizations. There's one we partnered up with this year called Embrace. So Embrace is a nonprofit that steps in after we have identified the patients, we have paid for their beginning stages. Embrace comes and embraces them and walks them through the entire process. So emotional support, advice on diet, understanding the stigmas and how to support that. There is so much that goes on across our country that really needs attention. But I realize that regardless of what walk of life you come from, whether you are extremely educated and exposed, or you are a market seller who in her own right is also earns a family, supports her family, we all need the education, and the stigmas bleed into all of us. So I've met women who are very educated in prayer camps and don't want to go to the hospital. I've met women who are not educated and advocate for going to the hospital. But as I speak to you, there are 2 men in Tamale. This will be the 6th man I have come across since I've been in Pink for Africa who have been affected and impacted with breast cancer. So as much as it's a women's disease, it leans more towards us. The men also, we're seeing more and more of the men. Unfortunately, the men are diagnosed at an early stage because men don't often check their breast. So the fatality of the diagnosed man is a little bit not so great in Ghana, but majority of the time, the men don't come up early. Our women, the struggle is the same. 12 years ago when I started till today, early detection is key. 60% of our women show up late, and so that affects the fatality rate, and our women are dying more because they show up late. We play with the herbalists, we play with the prayer houses. God is great, don't get me wrong. There's nothing wrong with having a support system spiritually that supports you. But no pastor should tell you, come to church alone and do not go to the hospital. God created the doctor and the nurses. I believe majority of our doctors, if not all of them, want to hit their chest and say, they saved your life. I am a product of that. So I think for me, it's not going to stop. It's going to continue. My focus is going to be even more. I'm going to work even harder to make sure that we educate and really begin to remove the stigmas that cripple us. Pink for Africa is supporting our youngest patient who is 16 at Kolibu. So for all of us, we are in this age group, this beautiful age group where our children are of this age. This is not anybody we don't know. This is crawling in closer and closer and closer to us. So we need it. We need to pass on our history to our children. That's another thing that affects us. We are diagnosed, we go into a shell, we don't tell anybody, we don't want to share our health history. I think for those of us who live outside of home, it's a lot different for us. But those of us who live in Ghana, those stigmas, all of the ones we've talked about, are really crippling us. As a woman, we should spread our tentacles and educate every woman around us and every man around us. It shouldn't be just women, it should be all of us. I was diagnosed at 40. all of the family members in my family, all the young ones. I have 3 sons. My boys have to be tested every single time. My son just turned 31 on Friday. He has to be checked and learn how to self-examine, because you never know. You know, early detection is why we're here. I've lost too many friends, and I want to grow old with all of you. I truly do. So I urge all of you, let's listen to our doctors who have taken the time out to tell us and show us and teach us. And let's not just this be a panel where we come together, talk, go home and not do anything about it. Let's be self-advocates of our own and then spread it on. Thank you so much.
Oh my goodness, Jules, thank you so much, Mrs. Juliet Mills-Luderud. I mean, thank you so much. And I hear that you actually are related to the Hobsons here. You have some sisters who went to Holy Child. Is that true? Did I hear correctly?
Yes, I do.
Yes,
I do.
We knew you, like Dr. Owusu, we knew that you guys were honorary Hobsons, so we're not surprised. But I want to thank I want to thank you for your eloquent words from your heart. I commend you for sharing. I know this is not easy. I know you've been doing it for a while, but you don't know us, we're strangers. And for you to come into our home and share this with us, we are so grateful. I know that there's somebody you touched. I know that. And I know that, you know, if you came into this world and you've done your duty, you're doing your duty by making sure that you're reaching out and you're using what happened to you to touch other lives. And so we thank you so much. I want to thank everybody who's still with us. We know that you could be using your Sunday for different things, but instead you're here learning with us and sharing with us. I want to especially thank our Wesley Girls past students in the audience. I also want to thank our Infante Man girls in the audience and also our Queens College women in the audience. I know that there are other schools here. We know that Augustine's is also here with us. And if I didn't mention your school, I am truly sorry, but I know that we are so grateful that you joined to make this a family affair and that this is not only Holy Child. As the panelists get ready, I want us to welcome them again and to thank them. And there are some questions in the chat. And so if you bear with me, I will start with those questions. And I'm not going to direct them to anyone, since I'm just going to let whoever thinks they can answer the question best be the one to answer the question. So I'm going to go through and hopefully I can do justice to these questions that people cared enough to put in our chat. The first question I have here, I don't know if Miss Ifya Pia is still with us. Ifya, I'm looking for you. I can't see you. And if you're there, I'm hoping somebody can put the spotlight on you. Oh, there she is. There she is, our gorgeous Ifya. Ifya, so you told a story that touched so many people. There was one thing you talked about when you said that, you know, you've been so active in this whole screening thing because of your family history, and you were getting your cousins to go along with you. However, when you got the first results and you were told that you needed to go and get further studies, you didn't go immediately. And I was wondering what kept you from not going immediately to seek care.
Okay, so I had a mammogram done in December, and I went with a group of friends, my sister, my mother, and it came back. It said, well, it was unclear, dense breast tissue. So I said I have to go and do more investigation. So I put the folder right in front of me in my office, and I would see the blue and white folder ever so often. But of course, you're so busy, you're running around doing things, and it slips your mind. So that was my first, that was my one mistake that I would caution everyone. Once you have the results and you're told to come in, don't run away, just go. Because my oncologist told me that from the pathology, if I had come then, it would have been precancerous, and then all I would have had to do was they just take out that mass of cells, and then I could continue with my life. So I do concede that I lost guard a lot. I should have done that. And I would caution everyone that, you know what, we're good at so many things, but the doctors and the radiologists, the scientists know this better than we do. And this is no time to be stubborn. You just have to listen to the doctors. They know it best. They've gone to school. You know, when you were introducing Cynthia, you know, all the things you were saying, yes. Well, school, so we should.
For our Nigerian sisters and other sisters on board.
Yes, yes, you know, and you don't have to. There's so many signs. You don't have to lose guard. You just have to follow up with your diagnosis and make sure that you get treatment.
Thank you so much. Thank you so much for being so thorough at that answer. There's another question that I have here, and I think it's a screening question. So Hetty and Kemi, it says, should I be scared of the radiation used during the mammogram? Will that do anything to me? Will that affect me?
Yeah, so this is a very common concern people have. So yes, the mammogram does use radiation to diagnose the breast cancer. It is a very, very small amount of radiation that we're using. And the way I like to tell people about it is that the radiation we're using, we're all exposed to some form of radiation as we go about our everyday life in our communities and on the streets, whether you're in Lagos or whether you're in New York, wherever, there's a lot of background radiation. And the amount of radiation you're getting from a mammogram is small and is about equivalent to what you would get from about 10 days to maybe 2 months of background exposure that you're getting. The other thing I like to tell people is, as Dr. Owusu talked about, when you do get diagnosed with breast cancer later, the amount of radiation that's going to be used to treat that breast cancer is orders of magnitude greater than the small amount that Hetty and I will be putting into your breast to diagnose the breast cancer. So it's a risk-benefit calculation. So we want to catch cancer very early with a small amount of radiation so that we do not have to see Dr. Owusu and have greater amounts of radiation used to treat the breast cancer. So that's the way I help people understand it.
Thank you so much. Miss Hetty Okran, I was going to ask, what can we do to decrease the fear of getting our breast mashed in that thing? I mean, that is, I think people think about that every year. Oh my God, I'm going again to get my breast. Is there anything to decrease the anxiety before we get that done? Or is there anything to decrease the discomfort during that procedure?
We have different patients. Patients' body habits play a role. Even though it looks like we're only taking image of the breast, we have your clavicle in the way. We have your chin in the way. If you are kyphotic, there are so many things that play a role. So even though we want to get to the breast, we want to get close to your chest bone and pull all the breast out, we have to get a lot of things in the way. So every patient is different. You have to trust the technologists that they know what they are doing. They have your best interests at heart, and just relax. Because when you come in and you are nervous, you are tensed, that makes the breast tissue tensed, and it makes it harder to even compress. And as I am compressing, you are pulling out because you are scared. And this becomes back and forth. I'm positioning, you are positioning yourself is back and forth. And that rather delays it and makes it more uncomfortable for you. So trust the technology is going to do the exam and know that they are there for you. They have your best interest at heart. And if you have any concerns, discuss it with the technologist. And then I have patients come in and tell me, my arm hurts, I have a shoulder pain. So I know how to approach it. And then, oh, I'm nervous. Then I will explain things to you better and we'll go along. But it's important that you get it done. So
yeah,
you have to be brave it out. And
yeah.
I have people taking pain medication because they are actually sensitive by nature. So they take pain medication before they come in. That relaxes them, their breasts. So
yeah, and I guess the message is that pain that you get from that one mammogram, the pain that you get from having breast cancer is just getting those lines placed. The magnitude you can't even compare. So we should.
And it's not necessarily painful. It is a discomfort because you wouldn't like your breast to be compressed.
Yeah. Dr. Cynthia Owusu, the question I have for you here is there a link between ovarian cancer and breast cancer?
So that is actually a very good question, and it happened to be the slides that I skipped, so it's very important that you've brought it up. There's a link, particularly in women who carry what we call the BRCA gene. These are abnormal genes that are inherited from parents. And when you inherit this gene and you carry this gene, you have a very high risk, about a 60 to 80% risk that you are going to be getting breast cancer. And in addition, you have about a 40 to 50% risk that you are going to be getting ovarian cancer. And even though it occurs in only 10% of women, there are certain risk factors that once we see a patient has them, then it means we have to arrange for them to get that testing done. And one of them being age. A young woman shouldn't be getting breast cancer. When you get 2 breast cancers at the same time, bilateral, that's a risk factor. If you are of Ashkenazi Jewish descent, if you have triple negative breast cancer, the recommendation has changed. Every triple negative breast cancer patient is to get BRCA testing because they are more likely to carry that gene. Once you get that testing done, if you are positive, then you have to make a decision. Are you going to get both breasts removed so that you don't get more breast cancer? Or if you haven't had breast cancer, you don't get it at all. Are you going to get your ovaries removed? And so some women make that decision and get their ovaries and their breast removed. Some women to decide we don't want to have any surgery. I'm going to take my chances, and we can give you hormonal therapy like tamoxifen and aromatase inhibitors to try and reduce your risk, but it's not as good as if you get surgery to remove.
Yeah, thank you so much. I don't know if anybody on the panel wanted to add anything. Okay. There's another question that says that the new studies show the newer body identical hormones do not increase the risk of breast cancer as previously thought. I'm assuming that that's for Dr. Cynthia Owusu. There's a statement somebody made that.
So can you repeat the question, the newer one?
It says HRT, new studies show the newer body identical hormones do not increase the risk of breast cancer as previously thought.
So I am not entirely sure about what the questioner means by identical hormones. As I think I may have repeated myself, if you have estrogen receptor positive breast cancer, or if you get estrogen replacement, it can increase your risk of breast cancer. In fact, if you have breast cancer and you're buying supplements or food, anything you're buying, putting into your body, you need to check the ingredients to make sure it doesn't contain estrogen and avoid that. So I'm not sure I've answered her question because I do not understand what she means by identical hormones.
Yeah, I wasn't sure what that meant either, but that was the question. Since she wrote it, I wanted to read it out. But there's enough. Thank you so much for that. Somebody was saying that they don't need a mammogram because no one in their family has breast cancer. So why are they wasting their time getting mammograms? I'm going to pick somebody, if anybody can answer.
Yeah, so I'd like to jump in on this because I hear this from my patients all the time. So yes, the women who have the genetic predisposition and the family history just know that their likelihood of breast cancer is greater. But 75% of the women that get breast cancer do not have any identifiable family history. Many of the risk factors that Dr. Owusu highlighted on her slide are very critical. The greatest one of them just being female and getting older. So it's really important that you get your screening mammogram every year. And I say every year because the other question I get is, oh, I had it last year. I don't have to come next year or the year before. No, breast cancer can start at any time. So just the fact that you had it in July of last year doesn't mean that you're good to go for the next 5 years. The recommendation, at least in the United States, from the American Cancer Society and the American College of Radiology, is that annual mammograms.
Thank you. Jules and Ify, I'm not going to put you on the spot, but I am putting you on the spot. I have questions for you. Somebody was asking, how easy is it to get mammograms in Ghana? In America, and I'm sure maybe in the UK, I can only speak for America. It's sort of, if you have insurance, you go and see your gyne, and then they schedule it, and then you get something in your email, and it's really made very easy. In Ghana, I wasn't sure. Somebody was asking how easy was it for you to get annual mammograms, and was it expensive? And perhaps that could be one of the reasons why people skip it, apart from the fact that you just forget about it.
So I'm in Ghana. Let me jump in a little bit. What commonly is done in Ghana is you go into the doctor and the nurse will self-examine you. So that's the first step. So that's the very first exposure to one, the nurse really taking time to see if there's anything abnormal at all. And at that point, then a mammogram is recommended, because women don't have the privilege or the financial backing to be able to go in as often as we have insurance and all the other support systems in the US. So once that self-examination process is achieved and the woman is suspected of a possible lump, then the other stages go on. There are some, right now, we are advocating for the government to give us, all of our women, free mammography. It is one of the things that we are pushing for through the health system. But you have to understand, we live in a country where the financial support of a cancer drug is already quite expensive. And the government tries to subsidize as much, not enough if you ask me, but on an average, yes, they try to subsidize, and other NGOs like me step in and pick the tab going forward. I think we initially started with supporting financially with chemo and radiation and all of that, but we noticed that women were coming in late. So our focus has shifted to paying for mammograms, paying for biopsies, paying for that early stages to encourage our women to come forward early. I'm not sure if you want to add to that, I would love that.
Okay, so when I started working with the Kolebu Breast team, one of the things we wanted to do was to make breast screening accessible to everyone across all the regions. So we formed a network of the tertiary public facilities across the country. So if you're in Tamale, you go to the Tamale Hospital. If you're in Kumasi, you go to Konfanoche, and so on. So the first thing was that the public sector facilities, and it was just so overwhelming that the private sector facilities also stepped in. So you have the health facilities and you have the diagnostic centers who are also stepping up. But it's mainly in October. So Eurocare, for example, will do will give you a breast screening and mammogram for about, I think it's either 195 cedis, which is way lower than what they normally charge in other months. I think Trust Hospital is pretty much around the same price range, but there's some facilities that I know give free mammograms, but I think the highest I know for October is 200 cedis. Yes, October, I actually say mine was a July find, and I don't wait for October. You should do it all the time. financially, yes, it's a challenge for some when it's not in October, but if you know that you don't want to get breast cancer, you would have to do it at a cost.
Thank you.
I certainly have to applaud you with the initiative, getting all the hospitals on board to do this. I have certainly noticed how helpful that is with me traveling through different parts of Ghana and recommending people to go to the hospital to get that free screening. So thank you so much for that. I think that is fantastic.
I know Dr. Owusu will have something to say, just because Jules mentioned the fact that when you go to the doctor, the nurse will do a breast exam on you. And if they feel something, then you get the screen, right? Is that what I heard?
Yes.
Sounds as though by that time it's not a screen anymore because you're actually feeling something. So the goal of screening is, and I'm going to let I'm a pediatrician, so I'm going to let the experts speak about it, is to make sure that you can feel, you don't want to be able to feel it. You want to catch it before you can feel it so that you can get the best results. Dr. Owusu, what do you think about self-exams? Because I still teach my teenagers at work to do the self-exam, and I sort of go through. Is this something that you're still doing? As I know it was a little bit controversial. Are you recommending that everybody do monthly self-exams?
Let me start off by saying that research has shown that self-breast exams do not translate to survival benefits. So the only screening test that has shown any benefit is mammogram. And under no circumstance should self-breast examination replace that. But what our sister is telling me is the reality. There's no mammogram, or people don't have money to do mammogram. So what are you going to do? Self-breast exam is better than nothing. It typically, unfortunately though, will pick up the lump when it's developed to a certain stage. Mammogram can pick up a lump that nobody can palpate. It can pick up the precancerous lesion, and self-breast exam will not do that. I continue to tell my patients to do it because many of my patients, actually, the first time they got diagnosed with breast cancer, even though they were even doing mammograms, was when they had a lump. And what Dr. Kimmy explained, I did mammogram this year, so next year I don't want to do it. In between, you can grow a lump. So quite often you have a patient who comes in between mammograms and they've been able to palpate a lump. But I emphasize that it should not replace mammogram because mammograms save life.
Wow, thank you so much. Excellent.
Jackie, can I add one thing about, because I know there are a lot of questions about people getting testing, and we know it's not always accessible to everybody. And I just want people to know that our recommendation also includes people who are untested relatives. The key is relatives. Know your family history. Yeah. I believe all our speakers who have been survivors have said something. Talk about it. Share it with your sister. Share it with your friends. Don't let this be a secret thing that you deal with. So even if you can't get tested to know if you have the gene, if you know that your mom, your auntie, your sister, your cousin, all these people have early breast cancers, that's really important to still tell Hetty and myself and your primary care physician, because the recommendations to get the screening for us is that we want to see you for screening, if you have access to screening, 10 years earlier than the age of onset of your closest relative. And for us, closest relative in this case is you have a twin sister, your sister, or your mother. So many of our patients don't get BRCA testing, but they know that family history and that sort of early screening starting at age 25 to 30, which is typically 10 years before their mother or sisters were diagnosed, is still very useful information for them to know, even if they don't go the route of getting that $3,000 BRCA test.
Wow, $3,000 in the US for the BRCA test? Is that what it costs?
Yes, I think some like Ambergen will give you a discount, but it's really quite expensive.
Does insurance cover it in the US or the UK?
I'll let Dr. Wusu answer.
Yes, and there's a process. If you miss that process, then you are going to be stuck with a bill. And so if you come to my office and you ask me to order the test for you, I can do that. It has to be ordered by the medical geneticist. And she has to see you in consultation, do an extensive family history like Dr. Kemi is saying, and clearly document that you fall into one of those groups. Based on that, she can go ahead and order it and insurance will pay, and it costs $3,000.
Ifya and Jules, did you guys, either of you, are either of you familiar with the BRCA gene tested in Ghana?
Well, we did, one of my cousins inquired about it, and when they did, he informed us that it was about 3,000, and we're like, let's see what the mammograms say. So definitely there's that, it is expensive. I believe you can do it in Ghana. And, but we didn't do it.
Dr. Wusu, is it even necessary, given Ifya's history, knowing that she'd had all these relatives with breast cancer, isn't it more important to use that $3,000 to pay for mammograms and treatment? So, will it make a difference doing the screen at this stage?
It is important to do it if you fall into one of those groups, because remember, you have, after you've had that breast cancer, if you don't have that information, if you did a very good thing, she got a double mastectomy, right? That's what you did. So she's taking that issue away, because that's what would have been offered if she had been BRCA positive. If you're BRCA positive, after that first cancer, you still have a 60% chance of getting another breast cancer. And then ovarian cancer is not as good as breast cancer. It is much more deadly, and you have that 40% risk. The other thing that I just want to briefly mention is that we now have, in addition, a new drug that if you are BRCA positive, we will give you in addition to your hormonal therapy, and it makes your hormonal therapy more effective. And so these are reasons why any woman who falls into that category ought to get tested if it's available and if it's affordable.
That's a good segue, actually, because we're talking about availability and affordability and access of care, because we know that when we're screening, anytime you want to screen, you want to make sure that you have a plan for the patient, right? So let's speak about our sisters in Ghana and in developing countries. Should they still screen, knowing that, should we have massive screening, knowing that therapy and treatment, those are still issues and those are not readily available? Or should we be working on both sides? Should we be working on the spectrum of things that we need? Because we're telling people to go screen, and then if therapy and treatment, if those are not readily available, what should we be doing?
Well, with my little experience that I've had in Ghana, I see that our doctors focus on removing the breast as quickly as possible to save your life. Majority of our women, after they come in and get either the surgery or tested, when they leave, they don't come back. Some of it is for financial reasons. Some of it is because a family member changed their mind. Some of it is because their pastor said, come into church. Some of it is because of their own fear. So the goal is, even when your tumors are found at an early stage, our doctors feel obligated to removing the entire breast. God forbid you don't come back. So in Africa, I don't know about different parts of Africa, but I know in Ghana, the goal is to try and save your life as much as possible. Because our women are showing up late, I think screening is fantastic, but we need to also have a support system for the screening financially. So as we go along with all of it, there are so many it's like a tree, right? With all these branches that needs to be supported. So we need the psychologist at Kolibu to understand her role in helping us. When I'm here for the month of October, I am pulled in so many different parts. I am pulled to come and counsel a woman who does not want to get her surgery. I am pulled to come and speak to someone who just got diagnosed. I am pulled to come and speak with someone to encourage her to even go through the very first step. So the dynamics of it is very different when it comes to how we are treated in the West, you know, in the rest of the world, that we have the access to everything, and then to Africa. So screening is very important. There's no question about it. We are at the mercy, like Doc said, we are at the mercy at that first stage where a nurse's hands can help to just encourage us to say, okay, let's move her to the next step. Even to get someone to that stage. Let me give you an example. Roche is a pharmaceutical company that is one of the biggest pharmaceutical companies for Herceptin. They have offered 18 cycles of Herceptin for free to any cancer patients who show up and need treatment. I have women calling me, telling me, I don't have transportation money to go get the treatment. So they don't show up. And these are some of the reality of what is at the back end of your market sellers, your cocoa sellers, your basic need for women who, it's real. The last bit of money she has left, she wants to feed her children. So she puts herself last. So as a small organization, we have to look at from the bottom all the way to the top, how we can help out. So that, it is a tough road, but it is one that I'm so appreciative of this platform right now, that we are really talking about so many different dynamics of breast cancer and how it impacts all of us globally, you know.
Jules, somebody just said, somebody put in the chat, they said that to support the work Pink for Africa, we want to remind our audience to please go ahead and donate to HOPSA, HOPSA.us.canada@gmail.com via Zelle or PayPal, because we really want to make sure that the work that Mrs. Juliet Mills-Luchard is doing is continued and replicated. We want to make sure that she does this in other places, because we know that this is such important work. And the fact that we've identified that she's doing this work is not a small thing. And we want to make sure that we help her. So please don't forget, anything that you have, think about your sister, think about if you were in that position and you couldn't afford transportation, she's doing the work, and let's try and support the amazing work that she's doing. I have another question, and unfortunately it's getting to 4. There's so many wonderful questions, and we appreciate every single question that the audience has asked. We'll try and share the slides, and again, you know this is recorded, and so hopefully you can listen to it again. I have a question for Dr. Cynthia Wusu. Is it possible that breast cancer has metastasized even before the double mastectomy?
So that's a very good question. And unfortunately, sometimes that is the case. Remember, I mentioned those microscopic cancer cells that nobody can see. So that is really what we're going after your surgery, when we say you need to come back for chemotherapy, you need to come back for hormonal therapy. So yes, some of these cancer cells might have escaped, but we can kill them. And that's the purpose of chemo, that's the purpose of hormonal therapy, that's the purpose of Herceptin. And as Ms. Jules mentioned, a lot of these Ghanaian women, it looks like they're not even returning for their adjuvant treatment. So if you get your mastectomy and you don't return for your adjuvant treatment, within a few months, within a few years, the cancer comes back. And I think that feeds into the myth in our Ghanaian community that once they touch your breast cancer with a knife, it spreads. It's because you didn't get your adjuvant treatment.
So as we're getting to the end of this session, what I'm going to say, we're going to send all the unanswered questions to the panelists. We'll make sure that these questions are answered. They're very important, and we know that we need to get you an answer. But as we get to the end, I want each panelist to tell us something that you don't want us to forget. You spend so much time with us, even though you have such busy schedules, and we want you to give us in part, we want to end this with a word of wisdom. If there was anything that we should take away from your presentation, what would it be? Even though we're going to take everything, what would it be if there was one thing you wanted us to take from your presentation? And let's start with Ifya. Ifya, just tell us what you'd like to share with us. I mean, we're so thankful that you've done what you've done. And we want to know what you would like to remind your sisters, your brothers, because those boys have mothers. And so we want them to hear what we have to say as well.
Yeah, so I think one thing that has helped me a lot is you don't do this alone. And if you find out that you have breast cancer, it's a journey, and it's not an easy journey psychologically, physically, but you don't do this alone. I know people who hide their breast cancer diagnosis, try and do it on their own, try and act like everything is okay. It's difficult, and there are people out there who are there to support you. So don't try to do this on your own, and share the information. Someone might learn from it. You don't do this alone. You don't do it alone. And there are so many languages of love. Someone will want to send you an apple, someone will want to send you a book. I get all these messages on my phone every morning. Some people will send you money, some people will send you body wash. It's just amazing. And you need that support to make it through. You need that support to make it through.
Thank you. Dr. Kemi Bagbeni, do you have any words of wisdom that you want to impart? Thank you so much, Ifya. Thank you so much.
So I wanted to thank the faces of the survivors and the victors who are here, because they are proof of what I'm going to say, that early detection is key. You can't let the fear of breast cancer prevent you from actually going to get screened for breast cancer. So if you learn nothing from all we've said today, is that early detection is key, and screening mammography, especially if you have access to it, even if it's diagnostic mammography that you're getting access to after you felt something, it's better to still get a mammogram and find out what's going on than to sort of be afraid and be scared and let things sort of progress to a point where they cannot be treated anymore. Your doctors are here for you, and your technologists too. Hetty and I kind of work hand in hand.
Mrs. Juliet Mills-Lutherard, any words of wisdom for us?
Absolutely. I just want to say that as women, we do so much for everybody. Please take time for yourself. Love on yourself a little bit more. And it's okay to be selfish. You know, taking time for yourself is important. Get that massage you need once a month. Treat yourself to a time with your friends, and learn to appreciate the woman you are today by loving your body and caring for your body, please.
Thank you. Thank you so much. Thank you so much. Dear Miss Hetty Henrietta Okran, any words of wisdom that you'd like to share with us?
All right. So one thing I want to say is the one thing that women are afraid of to take the mammogram, to come for mammogram, is the one important thing that has to be done: compression. Mammo is compression of the breast. It's to compress the breast, is to separate overlapping breast tissues so we can see any hidden lesions. So compression is very important. And compressing your breast, you don't determine how much your breast should be compressed. The technologists know how far to go depending on your breast density, your breast tissue, and your body, and what we are looking for. So compression is very important. So try to work with the technologist. You objecting the compression is limiting your finding. It goes against you. That becomes a waste of time. So work with your technologist, try to relax, follow directions, and get it done. That's what you came there for. So get it done. Thank you.
Thank you so much. And now, last but not the least, obviously, is our amazing, gracious Wesley Girls sister, Dr. Cynthia Owusu.
Okay, so I would like everybody to leave here knowing that breast cancer really ought to be viewed as a bump in the road. Gone are those days when if you got a breast cancer diagnosis, everybody's thinking doom and gloom. More than 95% of patients with breast cancer, once they receive their treatment, are completely cured, meaning the breast cancer is not coming back. So I want women to view breast cancer as a bump in the road, embrace the treatment, have a positive attitude. And lastly, prevention is better than cure, right? There are 3 simple things you can do to reduce the risk of breast cancer. Avoid alcohol, be physically active, and maintain a normal weight. Thank you.
Thank you so much. God bless you. As we are getting to the end of it, you know we have to end with prayer. But before we do, I want to introduce Miss Barbara Boama Frimpong. She's a member of the HOPSA class of 1996. She's also the 2nd Vice President and Organizing Secretary of HOPSA US Canada. She loves to be in the background. She's the reason we're doing this today. She organized everything. She got us all together, and she's the most humble person that I know. So she doesn't want me to introduce her, but I told her I was going to do that. She enjoys being helpful to anyone who needs help with anything she can help with. And she maintains that she wants to be known as one who loves life. I'm going to also invite our esteemed president, Miss Becky. Everybody's a doctor, forgive me, I'm at work, so I keep on referring to Miss Rebecca Liverpool Gums, Sister Becky, to close us out. It's been a remarkable afternoon. I am so blessed to be sitting here with the panelists that we have, for the people who shared their amazing story, especially to the audience. This would have been nothing without knowing that you are on the other side listening, and thank you for your participation. Please, please text a friend, text your sister, text your sister-in-law, text your classmates, send a WhatsApp chat, tell them, go get your mammogram. We are here for you. We're going to be in this together. You know, let's not make this something to be embarrassed of. This is life-saving, and I'm really, really hoping that after this, we can talk more freely about breast cancer and about cancer in general. We hope the next time we talk about, the next presentation we'll talk about cervical cancer, because that's also a big issue that we know that is easily preventable and that we don't talk about. So I'm going to ask Sister Becky to do the vote of thanks, and also to send us out in prayer, because we all know that without God, none of this would be possible. God bless you all. The panelists, we're so grateful. HOPSA thanks you, and we can't wait to do this again. Go get your mammogram. You're worth it.
Thank you, Jackie. Today's event has truly been a collaborative effort. On behalf of the executives of HOPSA USA Canada, I'd like to express appreciation to the following. Our dear friends from various alum organizations who sent photos and recorded videos to highlight awareness for the event. Our esteemed panelists, Henrietta, Kemi, and Cynthia, for carving out time of their busy schedules to prepare and deliver a thorough and outstanding presentation. I'm sure you all agree they did a phenomenal job. Our courageous sisters, Ifya Pierre, Mariatha, and Juliet Mills-Lutrot, for sharing their stories. Madam President, HOPSA UK, ACSL, for always being a willing collaborator. And to our moderator, Jackie, who kept us on schedule and beautifully executed the program, and Mary, who facilitated the interlude. To put something of this magnitude together, many people work behind the scenes. I would like to recognize, as Jackie has already done, HOPSA USA's Vice President and Organizing Secretary, Barbara Frimpong. Under Barbara's leadership, the team skillfully organized and executed this program. Kudos to you all. We'd also like to thank all of you who showed up and engaged. We truly appreciate you and hope that you will take what you've heard to heart. Get those mammograms, perform those self-checks, and lend yourself a support system Lend yourself as a support system to anyone you know who is going through treatment. Finally, would like to thank God, without whom none of this would have been possible. Please bow your heads. Heavenly Father, nothing we have done here has been without your help. Thank you for the knowledge that you give us each day and the wisdom with which to use it. Father, you've promised to give us each day our daily bread. Some of us need it in the form of healing, others encouragement, and still others peace, comfort, or financial well-being. We ask that you walk with Afia and all those currently going through treatment. We ask for comfort for those who are mourning the loss of loved ones, and ask for strength for those who are caring for their sick loved ones. We thank you for the work that Jules is doing with her organization, Pink for Africa, and ask that they will never be lacking in resources to continue this good work in women's lives. We commit the Society of Holy Child Jesus to you, and thank you for the vision of Cornelia Connolly, which led to producing Women of Substance. As we leave here today, I pray that you will bless each one of us with your peace and gift of good health. Amen.
Amen.
Amen. Can I ask everyone to turn on their cameras so we can take a quick picture before we all go?
This is incredible.
All come at the smile, everyone, on 3.
We're not done. We still have people getting cameras.
Okay. Okay. Let me know when everyone is ready. Uh-oh.
I think Sister Becky, we're taking a picture.
Yeah. Let's take the quick, real quick.
Sorry.
Let's take one quick picture. Okay. Okay, good. I got the first page, so that's good. We're good.
Get the second page.
Yes, got the second page. Should I do all the 5 pages?
I think it's 3.
There are 5, but not everybody has their camera on the.
Okay, I got the first 2, so.
Yeah, I think we're good.
Mhm.
It'd have been nice to capture the names as well, but we can get that at the end.
Yeah.
Okay. Incredible.